A very good morning to all the faculties and the postgraduate students. We'll be starting the first session of the last day of PediaRare 6. We have three presentations in the morning session: Space Management and Maintenance by Dr. Anshula Deshpande, Interceptive Orthodontics by Dr. Joby Peter, and Oral Labs by Dr. Subhadra N. And before we start the session, I would like to introduce the moderators for this session, that is Dr. Divya Sharma and Dr. Srinath SK. So Dr. Divya Sharma did her graduation in 1992 and post-graduation in 1996 from prestigious King George Medical College, Lucknow. She won gold medal for being the best intern. She has more than 60 national and international publications in a name reviewer for many national and international journals, has conducted national symposium with international speaker in Modern Dental College, Indore, August 2016. She recently contributed a chapter model analysis for mixed dentition and pediatric dentistry textbook edited by Dr. S.G. Damble. She was invited as guest speaker at IAPD 2019 conference, Cancun, Mexico. She has made mobile application now available as web application for mixed and permanent dentition model analysis Ortho Assistant, which is being used successfully by pediatric dentists. Welcome, ma'am. The second moderator of the day is Dr. S.K. Srinath, who is currently the professor and head of the Department of Pediatric and Preventive Dentistry, Government Dental College and Research Institute, Bengaluru. He is also a PhD guide, an independent director, Indian Medicines Pharmaceutical Corporation, Ministry of Ayush, Government of India, a member of PhD Registration Committee. He was chairman of Board of Studies for undergraduates 2021 to 2024 and also a member of the Board of Studies for post-graduation from 2018 to 2021. He is the chairman for Institutional Ethical Committee of Narayana Dental College, Nellore 2017 to 18. Welcome, sir.
Thank you. Thank you so much.
Now I request Dr. Divya Sharma to please introduce the first speaker of the day, Dr. Anshula Deshpande.
It's my privilege to introduce Dr. Anshula, although she doesn't need any introduction. So she is professor at KF Shah Dental College and Hospital currently, and she did her BDS in 2001, MDS in 2004 from Manipal College of Dental Sciences, Mahe, Manipal. Her additional her additional qualifications are MBA in Clinical Research Management, PG Diploma in Intellectual Property Rights Law, and PhD. Her academic achievements are many publications, that is 120 articles, one patent, and 18 books or chapters publication. She has also been awarded with Vidya Tandon Memorial Gold Medal as Best Outgoing Postgraduate Student, International Association of Dental Research, Colgate, Research in Prevention Award 2006, University Research Award 2018, Best Paper and Poster Awards in ISPPD Conference and Convention, and Distinguished Women Award from ISPPD. And he is reviewer to many national and international journals. Welcome, Dr. Anshula.
Thank you so much, ma'am. I'm really obliged and I'm humble. My greetings to my panelists, Dr. Divya ma'am and Dr. Srinath sir. I will request the organizers to allow me to share. Yes, thank you. So without any delay, as there is a long chain and there is a being fourth day of the program, I understand that everyone must be quite exhausted. So before I start my topic, I would like to acknowledge my guide, Dr. Shobha Tandon, all my teachers, mentors, ISPPD, Department of Pediatric Dentistry, Preventive Dentistry, KLE Society, Bangalore, my alma mater, and my department KM Shah Dental College and Hospital Sumandeep Vidyapeeth, where I'm currently working as. So as you all know, the topic which I have been allotted is space management and maintenance. Now, when we talk about it, I would like to put forth a very appropriate statement or saying given by Stewart in 1982. It is more difficult to hit a bull's eye on a moving target than on a stationary one. Unless the speed and direction is known, the accuracy to hit the target becomes merely a matter of chance. So, without taking these chances, if we have a good understanding, logical understanding, and analytic skill, we will be hitting the bull's eye. So, as this is a rapid review course, the most common question asked regarding the space management is role of space management in development of normal occlusion or management of space in developing occlusion. Now, if you see, the keywords are same, but many times we as examiners or evaluators, we see that we get different answers for both the questions. My advice to all the PGs who are going to appear for this exam, don't write a very theoretical answer. It looks like an unstructured answer. Ensure that you write your answer appropriately. First of all, if it is a 45, it's a long answer for 25 marks, allocate 45 minutes. And if it is a short answer question for 10 marks, you have to allocate 15 minutes. And yes, keep 3 minutes extra time to plan your answer, because I know it is tough for this topic to write in for 10 marks in 15 minutes. So with this, let me take you to the frequently asked questions which have appeared in various university papers. Management of space in developing occlusion, role of space management in development of normal occlusion, space management methods for the entire arch, fixed aesthetic space maintainer, concepts of early orthodontic intervention, modifications of band and loop, and changing perception in space management. Now, before I do the detailing, I would like to ensure that you should formulate a structured answer, as if the time is less, you should have more tables, more diagrams, and line diagrams and flowcharts in your answer. Now, the management of space in developing occlusion will usually appear as a long question. And the content of today's lecture is also the content of the question answer for this question for space management. Now, before I go into this, how many of you can recognize this chapter? Management 27 chapter, management of the developing occlusion. Yes, you all have guessed right. It is chapter 27 of McDonald's 10th edition. And in this chapter, they have beautifully and comprehensively described about what all management is required in developing occlusion. And the topic preventive management of the developing occlusion talks in elaboration about space maintenance and various methods to do that. But along with that, I would also recommend all the postgraduate students to read Pediatric Dentistry Scientific Foundation and Clinical Practice by Stewart, Bauer, Turkman, and V. And the chapter is chapter 19 in section 4 on guidance of developing occlusion, and 19th chapter is on space management. Lot of your, and even 18th chapter, occlusal development, the predictive problems and clinical implications. This will help you have a good knowledge base or foundation, have a better understanding to how to manage space in developing occlusion. Now, coming to content of the topic today, I will tell you introduction, terminologies. So we will revise this, objectives or importance of space management, dental arch dimension changes, growth assumptions crucial for understanding craniofacial and dental growth, various reasons for loss of space in primary dentition, the classification, needs assessment, arch analysis, factors influencing the developing malocclusion, changes seen after premature loss of teeth, space management at different dentition stages, space appliances with various modifications, conclusion and reference. So coming to role of space management in development of occlusion. Now, if role of space management is the question, then you can see here few in upper points are the answer, structured answer will remain same till the examination and factors. Then changes seen after premature loss of teeth. Then your question should highlight the role in various dentitions, that is primary, mixed and mixed dentition. So always ensure that you read the question and capture the keyword which is given in the question. As you can see here, if the question is space management methods for the entire arch, you have to give more emphasis on to dental arch dimension changes, that is buccal and anterior segment, various arch analysis methods, classification you can reduce to 1 or 2, describe various appliances and their modifications, and give example of both unilateral, bilateral, fixed and removable and functional appliances. Coming to fixed aesthetic space maintainer, again definition, objective, one classification which encompasses aesthetic space maintainers as well. Why aesthetic space maintainers are chosen above conventional space maintainers, and then you have to talk about around 4 to 5 space appliances, aesthetic space appliances, about their construction, advantages, disadvantages with literature review, and in it a conclusion and references. Coming to concepts of early orthodontic intervention, here your answer could be preventive management of the developing occlusion, in which your subheads will be planning for space maintenance, factors related to arch length adequacy, strategies for specific tooth loss, cause and correction of deleterious oral habits, and then phase-wise correction of the developing occlusion. Now, here you can see it is about early orthodontic intervention. So you have to balance your space management as well as habits in early orthodontic intervention. The other question which I had put forth was modifications of band and loop space maintainer. So you start with definition, then what is band and loop space maintainer? What are its uses, indications, contraindication, advantage, disadvantage, how it is constructed, so the steps of it, then the modifications, various modifications of band and loop, and conclusion. So I will be revising the various heads, whatever I have spoken in the answers. The very interesting question which I came across was changing perception in space management. Now here I'm giving you a nutshell in a tabular form, the various aspects. Earlier view, that was the traditional approach, and modern perspective, which is evidence-based in today's time. So you can first make the elaborate table, and then one by one, each and every aspect, you can elaborate that why modern perspective has come with various evidence. So primary objective earlier was to preserve all available space after premature tooth loss, whereas now we maintain or regain space only if analysis shows likely future crowding or malocclusion. Decision criteria was earlier was premature loss was equivalent to automatic space maintainer. Now it has become more case specific. Space analysis, eruption timing, skeletal pattern, and oral hygiene, all these parameters have to be evaluated. Use of appliances, earlier it was long-term fixed space maintainers for most of the cases, whereas now selective appliance use for minimal duration, frequent review, and modifiability of the appliances has taken a pivotal role. Coming to role of natural mechanism, often it was ignored. Assumption that space will always be lost was there, whereas now we keep in mind the leeway space, favorable eruption sequence, and growth is utilized strategically nowadays. Next aspect is approach to space loss. Prevent at all cost was the criteria. Now, sometimes allow controlled space closure if it improves occlusion, for example, if we require class 2 correction. Integration with orthodontics, it was earlier kept separate from interceptive orthodontics. It was regarded as preventive orthodontics. Now it has been integrated with interceptive orthodontics and growth modification. And that's why you will see whatever appliances which I will share, those have been modified to integrate with interceptive orthodontics as well, because we don't want to lose the important time of mixed dentition phase and growth modification. Next aspect is risk considered. Appliance risk, not a major factor in decision, whereas nowadays oral hygiene challenges, decalcification, soft tissue irritations are also being considered while choosing the space maintainer. The last one is follow. Appliance left until permanent teeth erupt and minimal review was required. But now you need to have a regular monitoring. Appliance modified or removed based on eruption and occlusion changes. So this is something which you all should be knowing, that how the perception has changed in today's time. Now let us move on to reviewing the whole topic and understand the normal or abnormal occlusion for space management. Now, before you start the introduction, very important is you should have an understanding of dental arch dimension changes. You should be aware of spacing as given by Baum in 1950. What are the transitional changes in transitional phase that is happening to arch length, and which changes which have been very nicely elaborated by Murray's in 1959 and Moyes in 1976, and the awareness and understanding of incisor liability, that is uprighting and retroclination of permanent incisor in relation to their basal bone. So these three aspects are very important to have an understanding of dental arch dimensional changes. Now, there are certain growth assumptions which are crucial for understanding and predicting craniofacial and dental growth. The first assumption is skeletal growth and arch width. Major arch width changes are not to be expected with continued growth. Changes in the facial-lingual inclination of teeth are certain, and that have to be kept in mind. Second assumption, which is by Profit 2009, is about constancy of molars relative to jaws and each other. Relative forward growth rates of maxilla and mandible should be matched for the tendency of molar entire buccal occlusion to remain stable or change predictability. So if you are aware of molar relationship, you are aware of prediction, how it may change further utilizing the spaces, it will help in better molar relationship. The next assumption is molar shift possibility, which happens usually due to leeway spaces, that is late mesial shift or because of premature loss of primary teeth. The fourth assumption is stability of incisors. Crowding observed in the lower incisors, usually it results in deliberate flaring of incisors to gain space, which is equal to transient symptomatic relief. But actually, it is not in the normal range. Fifth assumption, tooth size correlations. As long as the patient is from the phenotypic and genotypic group, as the, for example, from which the table is derived, then the calculation prediction is within the statistical limits, as we do for mixed model analysis by Moores, and we go for prediction table. That's why based on the genotypes, there are different equations which have been given by researchers so that you can modify it and have a more precise prediction for the space requirements. And the last assumption which I would like to put forth is constancy of facial patterns. Both increments and growth vectors of the skeletal components vary during the developmental period, implying that facial patterns are not entirely constant and can change over time. And that's why regular follow-up and monitoring is necessary. Coming to understanding of normal or abnormal occlusion for space management, you all should keep in mind, and you can make a table where you say what are the normal features, then what are self-correcting anomalies, and premature loss of primary teeth may result. So physiologic spacing, primate spaces, and flush terminal plane molar relationship are considered as normal, whereas anterior deep bite, retrocline, or ugly duckling stages, these are the few self-correcting anomalies which have to be also kept under follow-up and observation. Space loss due to proximal caries, extraction of teeth due to pathosis, and traumatic dental injuries are the common causes for premature loss of barriers teeth. That's what here it is stated, the various reasons due to trauma, due to dental caries, and presence of pathology conditions such as cyst. Dental caries, interproximal cavitations, if not treated in right time, it also results in loss of interproximal contacts. So you must have seen in many cases that if there are multiple proximal lesions in D and E, there will be a space loss and you will see early class 1 molar relationship in most of the cases. Another is ankylosed tooth, and many times various abnormal tooth structure, tooth shape anomalies may also result in space loss. When teeth adjacent to an ankylosed tooth continue to erupt and tip over the ankylosed molar due to the loss of contact point, again, it goes into understanding and analysis for space management. Now, the terminologies. What is space management? As stated by Graeber, the action taken to preserve the integrity of what appears to be the normal occlusion at a specific time. Management of premature tooth loss in primary dentition requires careful thought by the clinician because the consequences of proper or improper space maintenance may influence the dental development well into adolescence, as stated by Profit in 2012. Other terminologies are space maintenance. You should mention these terminologies. Space maintenance by Broer in 1941, space maintainer by Boucher in 1941, and space control definition by Gainsforth in 1955. So these are the definitions which you should quote in your answers. The objectives of space maintenance: preservation of primate space, preservation of the integrity of dental arches, normal occlusion place, and in case of anterior space maintenance, it should aid in aesthetics and phonetics. So these are the objectives of space maintenance. Now, why is space management important? Early loss of primary teeth may compromise the eruption of sextinous teeth. If there is a reduction in the arch length, you all are aware of, early intervention may save space for permanent tooth eruption, and loss of primary molar leads to the tooth distal to the newly created space to drift mesial, and the tooth mesial to the affected molar to drift distal into the space. So in the mixed dentition, the timing of permanent tooth eruption, timing of tooth loss, presence of permanent teeth, and extent of crowding must be taken into consideration. Premature loss of primary molar near the time of normal eruption of permanent tooth may accelerate the eruption and make space maintenance unnecessary, whereas premature loss of primary molar at a very early age delays the eruption of the permanent tooth. So these are the key aspects or the importance why maximum of space in developing occlusion in mixed dentition has to be carried out. Now, another understanding which is required is a tooth is like a cube and the forces are acting from 6 directions, which is also termed as symptomatic space deficiency. If arch integrity is disrupted by early loss, the problems may arise and it may affect the alignment of the permanent dentition. Opposing teeth can supra-erupt, more distal teeth can drift and tip mesially, and more forward teeth can drift and tip distal. Now there is, as I was saying, had stated earlier that the segment-wise understanding of space loss should be there. So there are two important segments, that is buccal segment, as you can see in the diagram, and the incisor segment. The space within the dental arch in the dimensions of right and left buccal segments should be kept in mind. The right and left incisor segments also should be monitored. Now here you can see premature loss of first destrous molars. The presence of second destrous molars provides barrier or resistance to space closure by forward forces produced by erupting first permanent molar. So as you can see, if E is there, there will be less chances of space closure. Whereas the permanent molar eruption using distal crown surfaces of destrous molars for guidance is used, and hence the understanding of primary molar relationship is very important. Here you should note that root apex position of erupting permanent molars when second destrous molars are missing prematurely. So you can see here that permanent molars erupt too far mesialward, whereas lower is tipped into space, upper in a more upright and bodily forward movement. Now, when we talk about the dependence on the sequence of eruption of the succeeding teeth, the molar intercuspation, and most important of all, the dental age of the patient is very important. That will decide the severity of space loss. Timing is important as the arch perimeter loss is most likely to occur when the first permanent molar is lost very early. It also may occur when the cusp of the permanent molars are shallow, and that's why the intercuspation is not there, and there is an end-to-end molar relationship combined with an unfavorable eruption sequence. Coming to appliance, many types of space maintainers have been designed to hold space in this region, but do not appliance that of primary cuspation, which must have the chance to move labially and a bit distally. That's why there are various modifications done in band and loop to allow this to happen. Then comes the literature review. These are the important key landmark studies which you must quote, and you can make a table or representation like this. As Northway said, 1984, there is a significant and continued space loss when the second primary molar is lost prematurely. Tennyson, 2008, in their systematic review, stated that in early loss of primary teeth, immediate space of 1.5 mm of space in the mandibular arch and 1 mm of loss in maxillary arch is seen. These are the classification given by Henrichsen in 1962, which you all are aware. So I will not go and explain this. Second classification is according to Hitchcock in 1973. Whenever you are giving classification, it should be given in ascending order. And if you have to, your answer is short, then give the classification according to Code on Dental Procedures and Nomenclature, CDT 2017. As given as fixed, removable, unilateral, and bilateral with examples. The another aspect is need assessment. It is very important, as in today's time, in the evidence-based approach, it is not just that model analysis will do your proper assessment. You need to do intraoral examination, facial analysis, as well as functional analysis before you move on to the extraoral, intraoral photographs, diagnostic dental cast, intraoral panoramic radiographs, and lateral cephalograms. So these all are mandatory when you are planning for space management, because space management is guiding the occlusion to normal. These are the various arch analysis which are done in permanent dentition. Mixed dentition, you should all be knowing what you will be doing: Hakaba, Hickson and Oldfather, Moyers, Nance Carey's total space, and Tanaka-Johnson analysis. Whereas for primary dentition, the two analyses are Boston University approach and Boston University approach using Tanaka-Johnson analysis. Now, what is Boston University approach? Quickly, I will share. This approach requires the presence of deciduous canines and first molars, which is as follows. The mesiodistal width of permanent mandibular canines and premolars will be equal to mesiodistal width of primary mandibular canine plus twice of mesiodistal width of primary mandibular first molar. So this is Boston University approach. This is the steps for model analysis given in Nikhil-Mava, which you all are already aware of. But I would like to highlight that how to do Moyer's model analysis if there is crowding, because I've seen most of the time students do a mistake in this. So let me tell you the step. Determine the amount of space needed for alignment of the incisor. Set the Bowley's gauge to a value equal to the sum of the widths of left central and lateral incisors. Place one point of the gauge at the midline of the alveolar crest between the central incisor and let the other part lie along the line of the dental arch on the left side. Mark on the tooth or the cast the precise point where the distal surface of the lateral incisor will be when it has been aligned. Repeat this process for the right arch as well. Compute the amount of space available to this, and then the steps remain same, and you have to check how much is the distance available from the mesial surface of molar to the point marked on the cast after correction of the malocclusion. So here you can see the deficiency was found to be 5.4 mm in maxillary arch and 3.5 based on Moyer's mixed dentition analysis. So this is the chart which we commonly use in the department. So keep these type of leaflets handy so that it is easy for you. Now the treatment options in maxillary arch, as now the traditions change. Earlier it would have been directly Nance palatal and lingual arch, but now we will think about expansion, we will think about proximal stripping of deciduous canine, and we may think of Nance holding arch after extraction. So these are the various options for mandibular arch. Extraction of primary deciduous second molars followed by lingual arch, lip bumper in mandibular arch. As on OPG, it showed that E's were mobile and ready for extraction. Then another aspect is needs assessment as given by Owen in 1971. You have to point this and maybe elaborate with two points. The instance, time elapsed since space loss, stage of development or dental age of the patient, amount of space closure already occurred, what is the direction of closure, eruption timing of the permanent successor as observed on OPG, amount of bone covering, the non-erupted tooth, abnormal oral musculature, and congenital absence of the permanent tooth. So these are the various local aspects which needs to be assessed before you plan your space management. So how to represent that in your answer? Make a table, local factors on the one side, what are the important features related to these factors, and then quote the studies, the evidence supporting these factors. So this is an example how you should make a table, and you will be able to reflect your depth of knowledge in your answer paper. Now, what are the changes seen after premature loss of teeth? Buccal segment, as you know, maxillary or mandibular effect depends on state of eruption of first permanent molar as stated. You should be aware of forces by muscles. If the tooth is lost at 3 to 5 years, little or no space loss associated with second primary molar shift, whereas the significant loss is seen if lost between 5 to 7 years. Whereas for second primary molar, more space loss if first permanent molar has already erupted, whereas if it happens in 2 to 5 years, no space loss should occur while the tooth is in the basal bone. But after that, there may be loss of space. Coming to anterior segment, if in primary canine, midline shift may happen and decrease in arch circumference may take place. Whereas in incisor area, space loss negligible at 2 years, whereas the maintainer or the space management for aesthetics and phonetics should be carried out. Again, the literature review for loss of primary teeth. These are the two important studies by Ronner ma'am, who gave the sequence of the most common tooth loss prematurely, and Ahmed et al. 2012 stated the prevalence of early loss of primary teeth was higher in boys as compared to girls, and the loss of primary teeth was higher at 8 years of age. So the sequence, the gender and the age has been stated. Now, various space appliances are 3 segments: guiding the erupting molar, bilateral space needs, and unilateral space needs. So you can classify like this and then elaborate on various. Now, how to make a decision? There are factors governing the selection of appliance, which was given in DCNA 1978, which are appliance integrity should be known, maintenance and modifiability. As we are dealing with dynamic occlusion, which one should be knowing the patient cooperation, cost, and the limitations to your appliance. So patient cooperation and cost is related to patient or parents' acceptance, whereas appliance integrity, maintenance, modifiability, limitations, these have to be judged and decided by the clinician and help the parents to decide on the appliance. Now, coming to management of space in primary dentition, always give these tables so that you don't write just theoretical answers. So you can state missing tooth on the other side, what appliance you will give for maxillary arch, and what will be your choice for mandibular arch. So if it is unilateral loss, crown and loop or band and loop, unilateral loss of primary second molar, no treatment until eruption of pars permanent, later TPA should be given. Whereas in mandibular arch, distal should. Bilateral loss of primary first molar, then bilateral band and loops for both maxilla and mandible. If there is a bilateral loss of primary second molars, no treatment until eruption of first permanent molar and later transpalatal arch. Whereas in mandible, bilateral distal shoe until the eruption of first permanent. If it is multiple loss, then saddle appliance until first permanent molars are erupted, then transpalatal, and similar in mandible arch. Then you have to give a review. This coming to management in early mixed dentition. So this is the table for if the loss is unilateral for DE, bilateral for DE, and if there is multiple bilateral primary molars loss, then what will be your choice of appliance? So this is a very comprehensive table, and it will take less time, and you will be able to reflect your depth of knowledge in your answers. Coming to late mixed dentition stage, for unilateral T, unilateral E loss, coming to bilateral loss of primary first molar, primary second molar, and multiple loss. So the choice is transpalatal and lingual holding arch. Now, I will take you to the different appliances. If the question comes on band and loop space maintainer, you have to state it is the most common appliance used in primary dentition, and its uses have to be enumerated, and you can make a diagram, a line diagram for band and loop. Then you have to give indication, as I have already stated in the previous tables, when band and loop is indicated. You have to enumerate various contraindications. I will not elaborate each point, as you all are aware. So just it's a revision. Then you will also talk about advantages and disadvantages of the appliance. Then coming to modification of band and loop, you have to give modification. If it is a 10-mark question, you have to give modification, give 2 points with the reference or the evidence to the appliance. Main is space maintainer, where the loop is made only on one side, only the lingual extraction is given. But the problem is disadvantages, it is less stable. Then crown and above crown band and loop is given. Wrap and Demirose modification, where stoppers can be used to prevent gingival slippage. Band and bar, long band and loop when DE both have been lost and the permanent incisors have not yet erupted. Bonded band and loop space maintainers, tube and loop space maintainer, which is also termed as which was consist of wire component with helix, which is fitted on the buccal tubes in molar. So this can be also, it can also help this modification in space regaining on activation of the coil. Another modification of band and loop is bonded type. So you can see here the wire has been bonded on the teeth. If the premolar has erupted, and many times what happens is 4 has erupted and we have to keep the space for 5. Here you can see it is a modification of band and loop, again bonded type, which was given by Gulick Sirkan in 2014. We also have nowadays free-form band and loop, which you all are aware, which have a short tube size for all types of cases. Number of the size is written on the bands, and then the extension for the distal shoe is also there. Recent advances have been 3D space maintainers, the 3D designing and then printing it or making it into a metal fabrication. Then you should give a table of literature review where the key studies are by Wright, who said band and loop types of space maintainer are one of the most frequently used appliances. Kroll in 1983 stated that use of either zinc phosphate or polycarboxylate cement to attach band and loop. That was in 1983. Now we use glass ionomer. You all know the reason, because of fluoride release. Band and loops are being used since long as a space maintainer with good high success rate. So the success rate by Baroni, Rajab and Fatian. And in spite of good patient compliance, disintegration of cement and soldier failure do occur, has been stated by Kirzioglu in 2004. So you should give author, year and study report related to band and loop in your answers. Then next, by Subramaniam et al. 2008, failure of fiber reinforced composite was compared with traditional band and loop. The mean survival time was stated to be 13 months for band and loop, and comparing band and loop with Ripon was carried out, and he found super splint to be least successful space maintainer in terms of long-term retention and gingival health. So these are the few studies which these tables should be ready with you to quote in your answer. Coming to modification, crown and loop space maintainer. This is again a variation, and these are the two references which you should quote. The most important is Christensen's and Fields 2017, where they stated crown and loop is not a recommended technique for space maintainer because it decreases the modifiability. So band over the crown would be recommended for band and loop. Coming to distal shoe, you all are aware it is used for space of primary second molar, permanent first molar to prevent the molar drifting in mandible. And the main objective is to retain and guide the eruption of permanent molar. As you can see here, this preformed distal shoe was used and the permanent molar has erupted and is in class 1 molar relationship. So you can see in the OPG, this was 1 year back, and this is 2 days back OPG where the 6 has erupted well, and it's now time to modify the appliance. Various modifications: crown and distal shoe, gingival saddle appliance, distal shoe fused with lingual arch. These are the various modifications which you can see by Chanchal et al. 2014, Willett's design of distal shoe, preformed distal shoe and modified distal shoe with rectangular distal extension and lingual component by Somvanshi in 2016. So this is a literature review which you should mention. So keep all these tables ready with you and by heart, because these are few authors which most of us remember doing these important landmark studies. I've already showed you the easy space maintainer, which is a bonded type, which can also help in space regaining. Lingual holding arch for mandible maintains mandibular arch length. It is fixed lingual arch which prevents lingual tipping of the permanent incisors, and it is a passive appliance. But if we have to make it active, then modifications are there like Holt's modification, active lingual arch incorporating expansion screw, and lingual arch with coil spring. These are the various modifications in literature. Coming to Nance palatal arch space maintainer, it was given by Nance in 1947 and he initially named it preventive lingual wire. Various modifications are modified Nance appliance for unilateral molar distalization, aesthetic Nance, modified Nance palatal arch with acrylic bite plane, modified Nance palatal for orthodontic eruption. Transpalatal arch is a TPA is a unilateral non-functional passive maxillary fixed appliance first reported by Gauchgarian in 1972, and the construction was described by Hill in 1975 and Ramtosorius and White in 1977. So this is a Groper's appliance, which most of you are using. This is fixed functional space maintainer for anterior region, removable space maintainer for anterior. These are the literature review for removable space maintainer. Dinser 1996 stated that results indicated that removable space maintainers may cease increase in intercanine arch width. That's why we have to use it caution. Failures occurred in 63% cases was stated by Quaderman in 1998 and recent Tulu in 2005 stated that mean survival time of space maintainer was 7 months for maxilla and 6 months in the mandible. So approximate average is 5 months for space maintainers fabricated in fourth arch. This is further various studies. So these are the studies which you should quote in your answers, which talks about the mean survival time of the appliance, success, and the comparison of both fixed and removable space maintainers, which led to increase in the number of microorganisms in oral cavity was stated by Eriken, whereas Udenverdiker to 2016 stated that Nance appliance showed the lesser deformation on jawbone than band and loop and transpalatal arch. So this is how you should quote. Then another modification, space regainers are Jaffe's appliance, which was given by Paul E. Jaffe in 1963. Open coil space regainer, which most of you, it is also called as herb space regainer. Most of you are doing it in your preclinical exercise. Gerber's appliance and lip bumper. These are also various appliances which are used for space regaining. In removable appliance space regainer, this is an appliance with dumbbell spring, which you can see along with Hawley's appliance. It consists of dumbbell constructed which extend buccolingually and an acrylic block is split here so that you can achieve expansion. There are new types of space regainer like nickel titanium wire bonded space regainer and double banded space regainer with lingual arch crossbow, which was developed by Dr. Paul Chilakar. And then your answer should end with conclusion that the few points which should highlight the child whose development is idle is what is important. Both diagnosis and treatment planning are empiric in managing space in developing occlusion. Space maintenance should be considered in terms of anterior and posterior space loss, and space maintenance is generally not required for missing primary incisors, but for aesthetic concerns and phonetics, and posterior space maintenance is a necessity. So let me take you to the most commonly asked question. So the first question is deciduous tooth as natural space maintainer. All efforts should be made to prevent early loss of deciduous dentition by way of prevention of caries and timely restoration of caries, as it is stated that it acts as a best natural space maintainer. These are the various references at the end which you should quote in your answer, which were already there. Now, quickly, few slides. I want to discuss few things. The common question, do we need to place a space maintainer whenever a destrous teeth is lost prematurely? What is your answer? I know most of you must have answered it. The answer is qualified no, for it depends on which destrous teeth is lost prematurely and from which arch and at what time. Any guesses for the reference? Yes, it is Scientific Foundation by Stewart and V. Now, this is what is natural space maintainer. I wanted to show you an example. This is a patient came to me in my OPD. You can see here the situation of crowding, multiple premature tooth loss. So here you can see both D and E are lost prematurely. But the molar relationship bilaterally remained class 1, though there was missing D and E. So what is the role of upper primary second molar in this case? Any guesses? Despite having edentulous space in lower left back tooth region, there is class 1 molar relationship. Yes, the answer is supra-eruption of 6-5 is preventing mesial migration of 3-6, and the proper intercuspation of teeth also plays an important role in prevention of mesial migration of 3-6 in this case. So there is a natural mechanism of preventing space loss. What are these? Leeway space utilization, early eruption of permanent first molars, and then intercuspation, normal eruption, sequence and timing. If the sequence is correct, the arch length is better preserved. Good oral musculature balance has to be there so that the forces acting from both buccal and lingual aspect are maintained. Intercanine width increase during growth has to be monitored, especially during early mixed dentition. The intercanine width increases naturally, especially in maxilla, allowing for better alignment without significant crowding. And the last point is physiological mesial drift balanced by occlusion, that is stable interdistinction with the opposing arch can limit excessive movement of molars and hence preventing the premature space loss. These are the few viva questions. The position of loop in band and loop space maintainer, thickness of the saluting cement, dimensions, most common complications, when will you remove band and loop? So I will answer a few questions. Thickness is 25 micrometers for tank 1, 53 micrometer for RMGIC. Position, as stated by Barber in 1982, loop should contact the mesial abutment at the contact point. The span of a space maintainer should last until the end of mixed dentition period, as stated by Stewart, 1982. Another question, a permanent teeth not erupted, why we cannot give Nance palatal? Why it can't be given? Because lingual arch, you can give, but why for Nance palatal as well? It can't be given before permanent molars erupt, and the appliance is cemented to maxillary first permanent molars. Usually, in the absence of erupted permanent molars, there is no stable posterior tooth structure to seat the bands and support the acrylic button on the palate. So primary second molars can't provide adequate long-term stability. Because why I've put this? Because I saw one case and one picture where they have given Nance palatal on E. They have smaller ground height, band retention is less reliable, their roots are undergoing resorption before exfoliation. So the appliance would likely loosen or fail when the primary molars exfoliates. So what to do if permanent molars haven't erupted? You should opt for alternative space maintainers like removable hollies, transpalatal arch on second primary molars, or acrylic plate with posterior rests. So off the park questions, mention and justify mixed dentition analysis. What will you do if negative space availability is there? Which current is used while welding? how much ampere and voltage, and why do you give lingual arch as a replacement for band loop when permanent teeth erupts? So these are the answers already given by Barber and Stewart. So I will give you the answer for active space maintainer, that is Holtz modification and Gerber space regainer. The voltage is 2 to 10 and 250 to 750 ampere current at 1/25th or 1/50th of a second for welding of stainless steel component. So with this, I would say best of luck to all of you, all the students who are appearing. If you have any questions, you can also contact me on my mail or my WhatsApp number. So thank you so much. With this, I will stop sharing. Thank you for your patience and giving me extra time, as this was a major question.
Good presentation.
Thank you, sir. Ma'am, you have to unmute.
Yeah, it was a very comprehensive, very wide, and you covered almost all the questions also, Viva questions also, and very valuable for the exam going students. Thank you very much. And really, I should congratulate you for your efforts with the authors, ears, everything as an ideal, I should say, presentation for the students should learn how to present in a good slides with less of the material, more of the talking. They're good.
Thank you, ma'am. Thank you.
May I add something to your
Yes,
lecture?
ma'am, definitely.
Okay. Uh, so in my app, I have introduced not only in app and upcoming chapter also two terminologies are the incisor space discrepancy and the buccal space discrepancy. Like I said, for Moyers, often it becomes very difficult where should be the alignment, ideal alignment of the incisors. So we predict it also almost. So that the discrepancy, if you are adding both of the discrepancy in the incisor region and in the buccal region, so it will come the space available will be accurate also, and it will be very less cumbersome without any prediction of where the incisor should be there after the alignment. So maybe that is more, and all the definitions are giving in the app, everything, how to measure it and how to document it, everything is there in the. Another thing that you have mentioned that wrap and Demiror's appliance. So that has a straight loop, a straight bar, horizontal bar. So that uh, help imitating the physiological width of intercanine width at the time of lateral incisor eruption, be it in maxilla or in the mandible. So there is a some statements are there by different authors who say the one of the case you also showed that there was a over eruption of supra eruption of the second primary molar, which was preventing from the distal aspect. But why didn't the canine also did not migrate distally? Because it was in a good class 1 relation. So that is the importance of class 1 canine relation. And if it is in class 1, and while the eruption of mandibular lateral incisors, like which is a Moose and Chadda's study also, the maximum intracanine width occurs at the time of mandibular lateral incisor eruption. Also in the, by RAP has given that it also occurs during the eruption of lateral incisor in maxilla also. So both are, if the, but for both the cases, class 1 canine relation is very mandatory. If it is lost because of atresion, because of caries, because of early loss, then usually distal migration of the anterior teeth also occurs. So that has to be kept in mind. So the requirement of a space analysis is very important. I always say do not look at the space, but where you are going to give a space maintainer, but also look the overall arch, so that we can intercept in an overall way, not the just a space, maintaining a space only. and also the maxillomandibular. Very, very much thank you that you also included. This function analysis also has to be done. That actually it is a lacking part. So it is a very good
Thank you,
lecture,
ma'am.
actually.
Thank you, ma'am. Thank you.
Question answers are there,
Yes, ma'am.
actually.
There are few
Yeah.
questions, not few. There are too many questions because it's a.
Should I answer
technical-
online?
Yeah, I'll just ask few of them. Others you can answer because the questions are still popping up. So I can't ask
Okay.
everything. I'll just ask few of them. They
Sure.
want space management in children with special healthcare needs, particularly ectodermal dysplasia and dentinogenesis imperfecta.
Yes, the need analysis, the need assessment has to be done, and OPG, cephalogram, the caries status, all these things have to be monitored, and one has to give a space maintainer if there is a chance of space loss. So OPG, dental age assessment, all the factors as stated by Owen have to be examined. And yes, space maintainer has to be given. But when it comes to special healthcare need, then their patient cooperation becomes very important, because if they cannot cooperate, and if, like for epileptic children, we should avoid appliances. In those patients we cannot give, because it may result into more life threatening situation. So we have to assess all these. In special healthcare needs, Down syndrome children, they are very cooperative. You can give space maintainers in them. We do orthodontic treatment also is done on Down's children. But if the child is cerebral palsy, epileptic, then we have to avoid these space maintainers. So there are so many factors which I've already stated have to be evaluated one by one, and then decision has to be made. But yes, epileptic, any such cases, we have to avoid unnecessary appliances and do a good follow, because many times we can prevent space loss, and by if good interdigitation is there, so all these aspects will play a.
Okay, ma'am. There's one more question regarding which factor has to be taken into consideration. If there is no bone overlying the succeedinous teeth, that has to be taken into consideration, or the amount of root formation that has occurred.
Okay, amount of root formation, all of you are aware that once the two-third root is formed, that is when the tooth starts erupting, and it results in resorption of the accessor, the tooth, the primary tooth. Now, if the tooth is not there, and that's why it is said that there is a late extraction or loss after the age of 7 years, then it will result in early or accelerated eruption of successor tooth. All this is given in McDonald's and Stiver finding, the scientific foundation. But if the root bud or the Nola stage is at an early stage, only 1/3 root is formed, then definitely, and though there is no, but there is no inherent eruptive forces in the developing tooth bud. So in that situation, one has to go for space management or space maintainer.
Okay. Quite a few people have asked about the role of intercanine width in space management, and does band and loop space maintainer restrict the intercanine width?
Yeah, I had stated in my lecture that we have to ensure the movement of canine. We have to opt for the appliance or the modification in band and loop, especially in early mixed dentition phase, when the eruption of permanent incisors have started. At that stage, there is a growth of the dental arch. It is given very beautifully in scientific foundation by V. That is the time where intercanine arch width will change, and we have to ensure that we allow this movement, the movement of primary canine. That's why I also stated why Nance palatal arch is not given in primary E, because we don't want to restrict the eruption, or the intercanine arch width increase will also happen. So That's why, as we are dealing with dynamic occlusion, we have to, that's why now the approach is also changing, that we have to keep monitoring, we have to keep modifying the appliance. And definitely the intercanine arch width increases in the early mixed dentition phase when the incisors transition is taking place. And another spurt will happen when there is late mixed dentition phase, when the eruption of premolars and canines takes place.
So I think we had discussed that Demiros and wrap appliance would be more beneficial for at the time of
Yes.
instead of band and loop, that the traditional loop, it should not engage a canine. Rather,
Canine.
the horizontal bar should be there on which canine can slip
Yes.
physiologically,
It should
disto-buccally.
allow
So that
the
would be.
distal
And
migration
there is a
of canine.
thesis soon to be published.
Last two questions before we wind up, ma'am.
Yeah,
What are the other names for band and loop space maintainer? Other names they've asked. Probably Viva they must have asked.
Yeah. So you have to give a proper name. It is a unilateral, fixed, non-functional space maintainer. But there are no other names of band and loop which I have come across. Yeah, modifications are there which are named. So for band and loop, different names are for the modified band and loop, not for the actual band and loop, the traditional band and loop. Like
Last,
mayonnaise, appliance, these various appliances.
and they've asked, probably somebody has asked a question which must have appeared in
So
their
then it
exam.
must be definitely the modifications of band and loop.
They must have not framed it properly. Space maintenance and punishment appliances, one question somebody has asked.
When we say punishment appliances, see, in habit breaking appliances, we use these terms. The terms used are reminder appliance and punishment appliance. So, if your modified appliance, which you have modified, is resulting in some sort of punishment like poking or disturbing, then it is termed as punishment appliance. Maybe some of the examiner or the teacher have evaluated their appliance. The appliance was not made according to the desired construction design. It was poking. It was not following the contour of the gingiva or the bone. That's why the teacher must have told that you have made a punishment space maintainer. That is the possibility. But as such, this is not the term used for the common space maintainers, which are there in the standard textbooks, which we follow in pediatric dentistry.
Okay, there are around 90 questions. Probably if some of you, some of the questions, if you can directly answer it in question and answer
Yeah,
part
sure.
of it, ma'am.
Meanwhile, I will try to answer.
I think many are asking about the name of the app. So earlier it was a mobile app available on the Play Store, Ortho Assistant. But now, because of the renewal policy, I have not done. So web space link is there, but very soon it with logo also it will come. So it will take about 3 months. It comes on a web. Then I will publicize it. So you all will come to know. Whosoever has a older mobile app, that is still running.
Okay, so meanwhile, I will copy all the questions and try to answer one by one here. And if, because you all will be engaged in next session, so I will try to put it in a PDF and share with all of you later. So if that is okay with all of you,
Yeah, thank you.
with
Thank
the
you.
organizers and the moderators.
Thank you, ma'am. It was a good presentation. I request Mr. Dev to please project the certificate of appreciation to Dr. Anshula. Thank you.
Thank Thank you. Thank you so much.
Now I request Dr. Srinath SK to please introduce the next speaker, Dr. Joby Peter, who will be speaking about interceptive orthodontics. Sir.
Thank you so much. Good morning. I'm glad to introduce Dr. Joby Peter. Dr. Joby Peter, an alumnus of MCOS Mangalore, did his MBA from Annamalai University, Tamil Nadu. Presently working as professor and head at Anu Dental College and Hospital, Kerala. Dr. Joby Peter is a distinguished academician and clinician specializing in pediatric and preventive dentistry with extensive national and international experience. He is known for pioneering work in biofunctional interceptive myofunctional therapy and commitment to advancing dental education through innovative online and offline platforms. He holds a LUI certification in Butico breathing and sleep related studies. In this field, he is notably the seventh professional trainer from India and first dentist from the country. He also holds a PG diploma in criminology and forensic science, also a certificate in sleep, neurobiology, medicine, and society from University of Michigan, USA. He is a certified trainer in tobacco intervention initiative programs. He is also the global head and course director in international fellowship programs and biofunctional interceptive and myofunctional therapy. That is Dr. Joby.
Thank you, sir. We are sorry to say that Dr. Joby Peter won't be joining us live. If Mr. Dev can project us slides and start with the slide presentation.
Hello everyone. Thank you so much for this wonderful opportunity. Yet again, one more session of rapid review. I hope everyone is safe and sound. And my topic for today is interceptive orthodontics there. Myself, Dr. Joby Peter, working as a professor head of the department at Anu Dental College there. So all of you are welcome to my college at any point, anytime. If you want to visit, please do call us and come and visit us. One of the many questions that has been asked with respect to interceptive orthodontics, I'm going to have a quick run about how to approach these questions and what are the things, the must needed things that you should include in your answers there. So you can see some important questions that have been asked with respect to interceptive orthodontics. The point here to understand is interceptive orthodontics is always asked as a 3-hour question. Sometimes it is asked as a 1-hour questions there. So sometimes it's a short note from interceptive orthodontic will be asked, sometimes like a full advanced like paper 3 also you can get questions from there. So it's very much important that you thoroughly learn interceptive orthodontic protocols when you attempt the university examination there. So what are the things, how you approach and write down? Always a synopsis of whatever it is, okay? So if I ask you that if it is a 3-hour question that is got to be asked you, you need a synopsis like this with introduction, definition, all those things is required there. And the procedures, various procedures done under interceptive orthodontics, and coming into the conclusion there. So you need a comprehensive synopsis. Your first page of your answer sheet must contain this synopsis there, and then you start elaborating one by one when it is asked as a as a question for a 3-hour there. If it is asked as a 10 mark, they won't ask interceptive orthodontics in pediatric dentistry for a 10 mark. They might ask you one procedure in this. For example, space regaining in pediatric dentistry and what is limitations and all. Then again, in that also space regaining, you need to write, and then you need a comprehensive synopsis with respect to that. We will discuss that. So what are we going to write on the introduction of interceptive orthodontics there? So some of the key studies which you cannot or you cannot omit is this study done by Kunal and Koch about the interceptive orthodontic, the orthodontics and occlusal management. Okay, this is a textbook. You must read this textbook where they have clearly explained the various interceptive protocols there. And orthodontic and orthopedic treatment in mixed dentition, 3rd edition. And this page number 1 to 7 is a good read for you to talk about interceptive orthodontics. So when in your answer sheet, when you write, these 3 authors' names should be there. Who are they? Angle, who has proposed expansion in early age there. And 3M concept by Melvin Moss, and total child approach by Alfred Rogers. These are the pioneers who have done research in with respect to management of crowding, management of skeletal, management of muscles. All these people have a peculiar aspect they researched, and they published a lot of articles there. So you should have mentioned about the experiments or the research done by these 3 authors there. Now, coming to definition of interceptive orthodontics, you have multiple definitions, but I would say at least these 2 definitions. One of the definitions, if you can memorize and write it, that will be good, as proposed by Graeber and proposed by American Association of Orthodontics. If you can put that definition, will be sufficient there. Now, coming to the need for interceptive orthodontics. So there are why you need interceptive orthodontics. So again, Ackerman and Profit in 1980 said 15% of developing malocclusion can be fully corrected in primary and mixed dentition if you catch them early there. Now, 1 in 3 community patients, they assessed for need for interceptive orthodontics. They said that 1 in 3 need some amount of interceptive orthodontics. So Richardson and et al. Article there. An Indian study, Sandhu and Bansal, they said that they have showed that interceptive orthodontics is the need of the hour. It is required there. They are categorized the amount of interceptive orthodontic needed in each state wise. So that's again a good Indian study you can add where they supported interceptive orthodontic need to be done there. And the latest one, an editorial writing that has come in 2023, which says that interceptive orthodontics, its awareness and prevention is the first curve. That's a beautiful thing, that which age. So that has clearly given that 0 to 3 years what kind of prevention need to be done, and 3 to 6 what kind of prevention, 6 and above till adolescence what kind of prevention. So that's an amazing approach they have given in this article there. Now, what is the aim of interceptive orthodontics? Well, main aim is to minimize the psychological implication like teasing for the child, procline teeth, child get teased or they get retroback. Prevent trauma. You can see the incisors get chipped off, avulsed, get fractured there because of the proclination. When they fall, and the first thing they got to hit is the anterior teeth there. Prevent the occurrence of dental pathology with respect to interceptive orthodontics like odontomes or the formation of malformation because of the position of the teeth, the dilaceration that can happen with the teeth get, the crowns get twisted, the roots get twisted because of the malformation or rotation that can happen. All those things can be prevented there. Reduce the crowding, maintain a good class 1 incisor relationship, and maintain the midlines correctly. That's the need, aim there. Now, this is a good slide that you can take a picture. The reasons, the etiology of, if you ask me, it is genetic and it is exogenous factors there. They are interconnected there. It could be a combination there. So interceptive orthodontics, if you ignore the hereditary factors or the local factors, it leads to accumulation and later lead into aggravation at 13 and 14 years. But doing interceptive orthodontics, you as a pediatric dentist, you are going to compensate it. you are going to reduce the effect and later lead into a camouflage kind of thing, then where you can avoid or extraction or surgical correction, you can do that. And this is one of the best textbook you can, if you want to refer, is Thomas Rakowski and the Graeber's textbooks of orthodontic and endofacial orthopedic treatment management there. Now, what is the timing? There are different authors who said when to start. Okay, so according to them, it's a more startable time is 9 to 11 years. But according to AIAO, you should screen the child at least when the first permanent molars or first permanent teeth erupts, and then you have to assess it, evaluate it, and start doing treatment then. So timing varies there. The procedures which you discuss, there are so many procedures are there which you already discussed. So we will discuss one by one the procedures there. Crowding, the management of crowding. So when you are going to attempt this question from the perspective of writing an exam, you need a definition. So what is the definition? There are two definitions, or at least this Richardson definition. If you put, it's a faulty relationship between mesodistal distance of the teeth and the jaw and the arch perimeter. So that's a very straightforward definition we can memorize there. And then comes types of crowding, because crowding can be classified into different types. Now, it can be a primary crowding, which is real tooth size arch discrepancy that leads into that. Secondary crowding is because of early loss of primary teeth and the permanent teeth have migrated or shifted or drifted, that is causing it. And finally, tertiary or late crowding is a phenomenon that has been genetic or environmental factors. The main determination is late growth development. See, the reason of late incisor crowding is the jaw was supposed to develop, supposed to grow during the second prepubertal time, but it was not allowed. Now, the reason could be genetic, or it could be local factors like hyperactive mentalis, habits, or somebody put a space paint in a bilateral band and loop space paint in after the eruption of lateral incisor, they forgot to remove it. They continued, so that restricted the transverse growth. So some kind of reason is present in a tertiary or late incisor crowding there. And the etiology. So the etiology could be genetic, like parents, the tooth size arch and discrepancy, or it could be local factors like loss of space or tipping of the teeth or supernumerary. So many things are there which can lead, so that you can write out to that. Now, how you diagnose crowding? Diagnosis of crowding is done basically the most important thing that you can see is a model analysis there, which calculate the Bolton's discrepancy, which calculate the position and inclination of the tooth in the models there. So Bolton's and the tooth size arch and discrepancy position, whether the buccally lingually placed, the inclination of the tooth can be easily assessed in the model. That's the use of a model for crowding presentation there. And there are different model analysis. You have, Tanaka Johnson's or Moyer's or any or Short's model analysis, you can use it. The more specific one, like a modified Hickson Oldfather, in primary dentition, I would say Hookabass or Ballard and Wiley analysis or Hickson and Oldfather's, the modified one, are very specific and sensitive analysis which can use them. Now, our aim is to come into a protocol where you categorize that whether space is present, is mild, moderate, or severe. Now, our treatment plan depending upon that. So once you do that, even that little irregularity index also you can add on to get additional points when you're giving a long essay. And you may not require this for a short essay or a 10 mark. You can finish with the model analysis and finish it off. But when you are writing a 3-hour paper, this is also required. Little irregularity index is also required, which classifies the irregularities present in the arch, mild, moderate, minimal, or severe, very severe there. So the management of crowding, the care management is if the crowding is under 2 mm, you can observe and you can just observe, and when and as and when you require, you can include appliance therapy there. So some authors have recommended disking of the primary teeth, especially the mesial and distal, the canine, during the process of eruption of the lateral incisors will be helped to align that itself. So that could be an option that you can give, disking with the help of a stripper or a proximal stripper, so you can do that. Or extractions, extractions like elective extraction of the deciduous canines are other option. The deciduous canine can be electively extracted there to relieve the crowdings there. Wilkinson's extraction, if said grossly decayed or unrestorable scope is less, then you think about removing those teeth to relieve the crowding that is present there. Elective extraction of second molars are also advised to relieve crowding that is present there. Therapeutic extractions, again, an option. As you all know, when crowding is present, you remove premolars. According to Betts and Tweeds, you can say that severe case of crowding, you align arch by with the help of a premolar extraction, align the arch that can be done there. Distalization is another method of gaining space in the dental arch for your crowding alignment there. You can use lip bumpers to regain space. You can use pendulum appliances, which are an amazing appliance which can dislice the molars and give sufficient spaces there. Or you can use rapid molar dislicers are also there. These are all appliances that can dislice the molars and can gain space and alleviate crowding in the dental arch. You can refer to this article which says there. Now, preservation with the help of a lingual arch is an amazing tool which can be used for crowding by moyers there. So this can leave mild to moderate amount of crowding can be, because the E space can be preserved and can be done there. Use of early age, like early mixed dentition, use of trainer system can also relieve crowding, which is according to Pujar, who said that early age, if you see signs of crowding is present, you can use trainer system and then you can relieve crowding there. You can see crowding is getting autocorrected with the help of a trainer system there. Use of functional regulators like trainers. You can use another myofunctional appliance called functional FR1P is very good to relieve crowding that is present there. You can expand the dental arch. We talked about distalization to regain space. Same way you can expand the arch. So it is a method of gaining space, expanding the arch. In crossbites also it is used. In class 3 management is also used. So we are talking about crowding here. So you can tell that expansion of the arch. And in medical reason also we use expansion of the arch is there. So when is the ideal time to expand the arch? Before the growth completion. So 12 to 13 years, much before that you should do expansion there. Earlier for females, and a little later, maybe 6 to 8 months later for the males there. So you need to check the CVMI, cervical vertebral maturation. Ideal time for maxillary expansion would be comes under CVMI stage 2, not before CVMI stage 3. So that's better for maxillary expansion there. Now, what are the types of expansion you do? The type of expansion is an orthodontic expansion where slow force is exerted and you use appliances which very minimal force is exerted. You use appliances like quadrilics or arch wires. Even your 2x4s in mild cases are very good for expansion there. Otherwise, you use Hawley's appliances you can use, or you can use quadrilics can be used to expand the dental arches. So these are appliances which give orthodontic forces, that slow maxillary expanders there. Now, which can be like a quadrilics, which are fixed, or the quadrilics is indicated in any cases of constriction of the maxilla. As early as you need expansion, you can give that. Cleft of maxilla, where there is constriction, the quadrilics can be used as early type. It is made up of a 0.036 L-giloy wire. It's a very beautiful wire, which has not a stainless steel wire. It has to be made with L-giloy wire, which is very soft, corrosion resistance, and less amount of force it acts. So that is the beauty of quadrilics that can be done there. If not quadrilics, another one is a NITA expander. Okay, that is also a good slow maxillary expander there, which can be given in mild to moderate cases there. The second option is passive expansion with the help of functional appliances or lip bumpers. They're all functional appliances which keep the muscles away and they expand the arch, or with the pressure from the muscles, they transmit onto the dental arch and they expand the arches there. So that is also the second option. The last option is the orthopedic expansion, true skeletal expansion, which is done with the help of a rapid maxillary expansion there, true skeletal expansion there. Huge amount of forces are given there. Within 3 weeks to 1 month, you finish expansion. Rapid maxillary expansion appliances you can give. So these are all ways to gain space for crowding, which can be applied there. Now the regime for rapid max expansion, you have Haas regime, you have Timms, Isaacson, and hybrid. You can see refer this article and you can note down this regime for rapid maxillary expansion. And which one is the most commonly used? I should say Timms regime is the most commonly used at this point of time, because it is very comfortable and least amount of pressure and less pain is produced when you follow Timms protocols. So that could be one thing that you can do. Now, rapid max expansion, and the use in OSA, it is very one, because when you expand the maxilla transversely, widen the nasal aperture, makes the palate wider, more room for your tongue, and you can train the tongue easily. You know that allow the tongue to go high there, and wider the gap, lesser the resistance to the airflow there, and it improves the nasal breathing there, and it definitely in the vilopharyngeal area also it improves the size and dimension, so that palate won't collapse and restricts, and snoring reduces when you expand them. Apnea hypopnea index reduces there, and a good option for OSA. So rapid max expansion is always a good option for that, and it reduces the nocturnal maturation in patients because of good sleep. It improves good sleep there. Okay, so that is about that. Now again, you have, if the child or patient is not competent enough or compliance is less, then you can think about in a late mixed condition, you can think about implant supported rapid maxillary expansion there. If adults, then you have to go for surgically supported rapid maxillary expansion, either SARPE or a dome procedure. Distraction, osteogenesis of maxillary expansion, that has to be done there. So that is the protocol to be done in adults there. In mandible, you have shorts expanders for the mandible. You can give rapid max expansion in the maxilla, and then you can give slow max expanders in the mandible, either removable or fixed there. So the combination also works very good. Williams mandible expanders or lower chordalics or shorts removable. There are two others are fixed. That can be also be done there. Lower Cozart appliances which can expand the maxilla can also be given there. So the fundamental principle in management of crowding when you write is you make the foot and shoe principle, which is proposed by the foot is the mandible, shoe is the maxilla. So you expand you make a bigger shoe, the foot can fit inside. So you get a lot of space management, auto correction happen there. So you identify if the foot is if the shoe is longer, narrow, constricted, you expand them so that the shoe become wider, so that foot can fit inside, and the foot and shoe principle is being done there. The next important part is the serial extraction protocol there. Serial extraction, again, when you attempt this question, it should have this synopsis when you write that. So this is very important for serial extraction. Introduction, definition, history, rational indication, contraindication, procedures, appliance there, and stages in serial extraction. If not serial extraction, what are other alternatives present there? And then goes on to the advantage, disadvantage, problems in serial extractions, appliance used along serial extraction, controversies in serial extraction, conclusion. So this could be your synopsis when you write. Because even serial extraction can come as a 1 hour, can come as a 3 hour question there. So that's why that detailed thing. The question could be defined interceptive orthodontics, classify or find the different interceptive orthodontic procedure, and write in detail about serial extraction and its application in preventive and interceptive orthodontics in pediatric dentistry. So it's a big question which can cover 3 hours there. So you need an approach of this synopsis there. So definition by Joel it's no, there are so many definitions. So you stick on to one or two good definitions. I said Dwell's definitions of seal extraction is good. You can profit definitions of seal extraction is also it's okay. So American Association of Orthodontics definition is also good. So at least among these three, one or two definitions you note it down and you write it down. You have to study that about with respect to seal extraction there. Now, coming to the diagnosis and treatment planning for seal extraction, you need to do a space analysis first, then you do a self-analysis and a soft tissue analysis. You require that. Without this, you cannot plan for a seal extraction there. So what are the space analysis done? The conventional dental oriented analysis like mixed dentition analysis is good, followed by Tweed's method, a facial oriented analysis where you need to do set values and a modification for that is done with the help of a soft tissue called Z line there. And Liveron Merrifield analysis proposed by Charles H. Tweed International Foundation for Orthodontic Research is also required for that. So any conventional analysis, either Moyer's or Tanaka-Johnson's to find out crowding present or not. So you got crowding. Mild one, you know the method. Moderate also okay. Severe amount of crowding, then you categorize them. Okay, it's a severe one. And then let me go into that. Let me see how much space is required. It is more severe, then you think about seal extraction to be done there. Then you do a Tweed's analysis there. And in the Tweed's analysis, you do a cephalometric correction of space required. What do you mean by cephalometric correction? Tweed said the lower incisor should be upright in the mandibular arch. So if the lower incisor, when you analyze the cephalometric value, if they are proclined, you need to upright them. So every 1 mm of upright require 2 mm of space there. So you have to add on to your conventional space required. You have to add on these values and then you get a final value of how much space requirement that is present there. So if it is beyond 10 mm, definitely you need to remove premolar and then to upright them there. So, and then a modification to this is a Z line, is a line, it is like a lip thickness and chin size. You draw Z line according to the Frankfurt horizontal plane, and then you draw a line from the tip of the nose to the soft tissue pogonion, you draw a line, and that is a Z line, and see the thickness of the lip and the chin that is present, and if they are full or if they are already out of the Z line, definitely you need to take it inside. So you need additional spaces there. So the space required, you do the tooth measurement by conventional analysis plus cephalometric modification by Tweed's method and plus the Z line, soft tissue one. So you combine both this, that is the space required. It could be huge. And then if it is beyond the rapid max expansion can do, you think about seal extraction can be done there. And the cephalometric analysis, which we do, is called the facial proportional analysis there. So that is the space required. To find out space required, you need Tweed's method, conventional modern analysis, plus you need Tweed's method and the modification there. So that will give you the space required. Now the cephalometric analysis, the real cephalometric analysis required for categorizing the patient into skeletal types or facial proportional analysis there. It's a composite cephalometric analysis which combines Steiner's, Merrifield and Tweed's analysis. All these compartments from this analysis, composite analysis is done in order to get into the different parts of the skeletal structure of the cranial face there, like anterior cranial base, posterior cranial base, all those things are being analyzed with the help of points from Steiner's, Merrifield and Tweed's analysis there, which categorize the patient into different categories. So it's an elaborate cephalometric and model procedure to decide seal extraction. That is why this method was not very popularized, because it required tremendous effort from the side of the practitioners to come into a diagnosis and give a good predictable results there. So standard or orthognathic phase, according to, after doing the cephalometric analysis, standard or orthognathic phase is where the maxillary and mandibular skeletal are in one line and the the dental compartment, the dentoalveolar compartment are also well developed. We call as a orthognathic face. In this case, if that means to say that SN and SNP are at the normal according to Steiners and McNamara, and everything is normal. Every skeletal compartment and the dental compartment is normal. So orthognathic face is present. You find out the patient is an orthognathic profile, but there is a severe crowding which we have done. Amount of space is 12 mm. You can do CL extraction there. Now cases where dentoalveolar protrusion, the case is an orthognathic, but if the teeth are proclined out, the orthognathic face or the skeleton, but teeth are proclined out, now it can come either class 1, class 2 and class 3. Dentally it can be class 1, class 2, class 3. Skeletally they are normal orthognathic, but dentally there can be class 1, class 2, class 3. In those conditions, only in class 1 and you do seal extraction. In class 2, you do only seal extraction in maxilla, not in mandible. And in class 3, never ever seal extraction protocol is done there. Now, what about dentoalveolar retrusion? The maxilla mandible skeleton are normal, but the teeth are retruded inside. It can in a class 1, class 2, never ever you do dentoalveolar, seal extraction is never done in a retrusion kind of case. You will never have a retrusion with a class 3. So you don't have to worry about it. So maxilla mandible normal in orthognathic profile with retruded maxilla mandibular teeth, you won't do seal extraction. In case of prognathism, where the teeth are out, what will happen? Class 1, maxillomandibular prognathism with a severe crowding, seal extraction is indicated there. But class 2, where they are maxillary prognathism, it is not indicated. Seal extraction is the choice there. Same way, maxillomandibular retrusion, they are behind or inside. Class 1 with maxillary mandibular retrognatism or class 2 with mandibular retrognatism, you never ever do. So in every retrognatism cases, you have no option of seal extraction. Prognathism, either maxillomandible tooth or skeleton, there's an opportunity, especially with seal extraction there. Now, what are the methods used? There are so many methods are used for adopting seal extraction. There are reasons for that. You need to explain dwells, modified dwells, nans, tweaks. So many methods are. And alternative methods are also there where the seal extraction is not completed exactly by dwell and modified dwell there. For example, you only do C and along with the D you enucleate 4. Sometimes you do C, D, E and even 4. Sometimes you do C, D, no permanent tooth extraction, which is my favorite, which I do in my practice there, and I substitute with this expansion with them. So there are 6 different methods of practicing seal extraction that can be done there. And must have to have is controversies in seal extraction. Controversies in diagnosis, controversies, because there are such an elaborate procedure it is. And so many controversies are there. So many errors can happen there. Like that, there are some 7 to 8 controversies are present in seal extraction, which you need to write in your long essays or condense and short it down. One of the best article you can refer is in the Imperial Journal of Interdisciplinary Research. A beautiful article by Vaidehi et al. Has come where the controversies in seal extraction are reviewed. It's a good article. Relevant points are there. You can refer this article and you can note down the points with that. So also next procedure is crossbite correction. So again, the synopsis of crossbites, let me quickly run down. You should have a synopsis of crossbite, which should be present when you ask to write a crossbite and its management there. Again, definition of crossbite, at least one definition of crossbite you must write, either Graeber's or American Association of Orthodontics definitions with respect to exam point of view. Classification of crossbite, simple profit classification is the best one. 2007 of crossbite, dental skeletal combined. And when you call a dental, when you call a skeletal there, or Subramanian et al. 2007 has given an elaborate flowchart of crossbites, anterior, posterior. Anterior can be dental, skeletal, and functional. Posterior, it's a beautiful crossbite classification, which you can do that. So that also you can refer the articles by Subramanian et al. 2007 there. What is the treatment plan? The etiology of crossbite, genetic or local factors, which you already know, that is again all interceptive has got that part there. Then treatment plan, management of crossbites in primary dentition, mixed dentition, permanent dentition. That is the key line that you should follow there. So crossbite in the anterior crossbite management in the primary dentition, so many protocols are there, like a pseudoclass. They find out whether it is pseudoclass, how the path of closure of the mandible in centric occlusion and centric relation. What is the path of closure, and find out is the occlusal discrepancies causing the mandible to get into centric occlusion from centric relation by jumping the mandible forward is a pseudoclass, which need to be correct as early as possible. So pseudoclass there. So there should be, there's a protocol need to be followed there. You can give removable appliance like Howley's appliance with auxiliary springs or expanders. All those things can be given there. Okay, with inverted label bows like this to correct the anterior proclination can be given there. Modified quad helix appliance can be given there. So these appliances are all appliances that expand the maxilla, correct the tooth kind of crossbite that is present there. Removable inclined planes can be given, fixed inclined planes, reversed in block can be given, planus track can also be given to correct the crossbite. So these are the methods. You have to elaborate each and everything. How long you have to give a removable inclined plane, fixed inclined plane, what are the indications, all those things you have to little explain it more. FR3 is a good appliance where you can give for maxillary hypoplasia, upper incisors or retroclined, which will steer the eruption of the permanent teeth. So FR3 is best in primary or even the late primary dentition towards the eruption of central incisors. They are just about to erupt. That's a very good one. And where the maxilla is smaller, it can widen the maxilla there. Now coming to the posterior crossbite, expansion of that. We discussed about expansion. You definitely need. If it is a single tooth, you need slow max expander. Even if it is a one-sided expansion, fixed RME or fixed SME would be better. Or if it's both sides, it's a skeletal, so definitely you need a rapid maxillary expansion appliances there. Now coming to mixed dentition, developing crossbites, even the teeth are in the process of erupting incisors, finger pressure also helps you. Tongue blades can be given. These are the authors which you can quote who suggested either finger pressure to tongue blades can be done in just developing stages there. Developed crossbites in mixed dentition, definitely the appliance of choice is either removable if it's a single tooth. Like inclined planes. The single tooth crossbites can be easily corrected with or small segments of tooth are in crossbite which can be corrected with this there. Otherwise, you need to go for fixed appliances. More number of units are there. You need more fixed kind of appliances to be done there. 2x4s are also good. Utility arch and all are good to correct the your dental crossbite that is present there. Otherwise, more segments are there. Definitely, rapid maxillary expanders are the choice when more units and segment are in crossbite that is present there. In permanent dentition, the management of crossbite is same as the mixed dentition, but fixed appliances are more preferred rather than your removable appliances in permanent dentition. So multi-branded fixed appliances along with the rapid max expand and along with fixed appliance are all the one that can be used in permanent dentition there. If it is too late, then SARPE or implant support expansion could be the option which we already discussed there. As and when the age goes more into adolescence, you need more kind of expanders there. Severe crossbites require orthognathic surgery. You have to assess the deviation or midline deviation, facial symmetry, and if it is very severe, believe me, you need an orthognathic support by a surgeon is required. Leaford 1 or mid-palatal corticotomy for wide mandible, body osteotomy, constriction anterior. All these procedures are done by surgical one. In adult one, severe facial asymmetry deformity that is present there. Then comes space regainers. The other next part is a space regainer appliances there. So again, that's been asked as a short note, and you need this synopsis to be put for space regainers there to regain spaces in the arch. So coil spring, very important. Open coil spring, which open up the spaces, are good for space regainers along with your straight wear. So one option is straight wear along with coil springs can be used there. Gerber space regainer, you know that can be used to regain the spaces. Gerber space regainer. Lip bumper is a good space regainer. And modified lip bumper with coil spring, again dislice the molar, can be a space regainer. Rapid molar displacer are again a good space regainer. Unilateral or bilateral one are space regainers which can regain the spaces. You can even use coil springs also there. Pendulum appliance is also a good space regainer that can be done there. Many implant supported space regaining is also happening to regain a space that is present in the distal aspect there. So if you want to read more about space regainer, this is a good article where a review of all the space regainers is given there. So you can refer this article and this is very good there. So if you want more, McDonald and Avery, 8th edition, space regaining appliances are there. New design for space lingual arch, crossbow and double banded space regainer are there. Space regainers in Pediatric Dentistry International Dental and Medical Journal Advanced Review article. So all these journal references, if you want to read more about space regainers, you can see. So I have given you the review, I have given you the synopsis and various space regainers which are being used in pediatric dentistry to regain either unilateral or bilateral spaces that have been lost there. Okay. Now, skeletal mal relation. One question, there are two questions that has been asked is interception of skeletal mal relation in pediatric dentistry. There are two, one class 2 management and class 3 management is been asked there. So mandibular retrognathism or class 2 management is a very common question that we have seen there. Early management class 2 malocclusion there. So again, it is again, you know, introduction should have the incidence and prevalence, the consequences, the effect of class 2, all those things should come there. Now, what are the reasons? Genetics, dental or environmental factors always comes there. So class 2 Div1, dental features and cost. You know the dental features of increased proclination, deep, although I don't have to tell and make you boring here. Second thing is class 2 Div2, what are the dental features and the external features present, that definitely you can write it down. Now, development of class 2, the local factors could be one reason. Like a function, like a habits or like mouth breathing, like a thumb sucking, or some habits could be the reason, like low tongue posture, which constricts the maxilla and constrict the mandible there. So there are which lead to type 2 or 3 types of class 3s, class 2s are there. One is maxilla is smaller, mandible is normal. Oh, sorry, maxilla is constricted, mandible is constricted there. The best one for this is functional orthopedic appliances there. You need to develop maxilla, develop mandible. So functional orthopedic appliances are the best one, like, you know, appliances like a rapid maxilla expansion, along with protraction, along with your mandible advancement kind of appliances are the best one to do this. The second type of is maxilla is constricted, mandible is normal, where you can use slow maxillary expanders or rapid max expanders can be used to develop the maxilla. The mandible is normal, so you don't need a mandible advancement appliance is not required there. The third type is constriction of the maxillary arch and mandible is retrognathic. So mean to say that mandible length and everything is fine, but it's retrognathic. Here you need twin block and reconators appliances are required to develop the mandible, because mandible is posteriorly placed. You need to bring it forward. So this kind of appliances are required there. If you read, this is one of the beautiful article where you can refer is class 2 management in mixed dentition by Rondeau in Journal of Clinical Pediatric Dentistry is an amazing article that you can read. So it's in around 1994, but now the protocols have been different, changed, where you have newer classifications of mandibular retrognathism or types have been emerging there. So that is by you know, the articles by Sassoni's bottom line analysis or Jefferson's skeletal classification, where you have type 2B and type 2C, where you can have to advance the mandible in type 2B. So all the appliances like FR2, MyoBrace class 2 trainers, or your activator, your bionator, whatever it is to advance mandible has to be given in type 2B. In type 2C, again, advancement of the mandible to rustic, you add hypo headgears. Okay, high pull head gears are added on to these appliances to restrict the maxillary growth or control the maxillary growth and advance the mandible depth. The next one is management of class 3. Again, you have these protocols which, the synopsis is to be given. The introduction, definition, all the signs and symptoms, everything should be done. Now, what are the protocols to manage? Again, you need rapid maxillary expansion and face mask. You have to advance the mandible depth. Alt-RAMAC protocol, alternative rapid maxillary expansion and contraction and protraction can be given there. And all these protocols should be mentioned in your cases that is present there. If you want, you read this article. It's a good article by AGO given by Nagan and Moon et al. Evolution of Class 3 Treatment in Orthodontics. It's published in American Journal of Orthodontics and Endophysio Orthopedics. It's a good article and you can get all the management protocol. Again, a good article that has come in recently, expert consensus in early orthodontic treatment of class 3 malocclusion. It's a beautiful article which explains the various protocols that can be applied for the management there. So guys, this is like till 1 month before examination. So all the 3 years you'll be like this, and now the rapid review has come. You are preparing, running, and fast for the examination there. So guys, have good food, good mood, and good sleep. You do it before. That is important to memorize things, to make things stable in your mind. Whatever you read, if it's not stable, then you need good food and good mood and good sleep so that you can memorize, recollect, and relax. And let me wish you all the best for you. So MD's examination, you have cases to be ready, short study to be ready, thesis to be ready, journals, JC, seminars, books, and the PGs are there. Then examiners are all evaluating every aspect, and you are the postgraduate to be evaluated and being there for the past 3 years there. So this is, you can catch me at any time. Thank you so much. I once again the office bearers of ISPPD for conducting this, especially Dr. Madhu and the team for inviting me, giving me this opportunity to present interceptive and myofunctional part, the rapid review part, the most important question that has been asked. Thank you once again to the entire team for giving me this opportunity. So thank you so much. All the best and good luck to all of you.
Nice presentation.
Thank you, sir. We're extremely sorry to say that Dr. Joby Peter won't be available for some unavoidable circumstances. Whatever the questions the students have posed on the Q&A, we'll compile it into a PDF, send it to sir, get the answers from him, and post it on the ISPPD website. That will be assured. So we'll go to the next topic for today, that is presented by Dr. Subhadra. The topic is oral habits. And before we go to that, I would like to present the certificate of appreciation to Dr. Joby Peter. Thank you. Now I request Dr. Divya Sharma to please introduce the next speaker, Dr. Subhadra H N. Dr. Subhadra H N. Thank you. Divya ma'am, if you can please introduce Dr. Subhadra H N.
I don't know. Okay, am I audible?
Yes, ma'am.
Okay. Welcome, Dr. Subhadra. He did her education from JSS Dental College and Hospital, Mysore, and MDS in Bapuji Dental College and Hospital, Davangere. She got a PG diploma in Nutrition and Clinical Dietetics, Medversity, Hyderabad, And she is got a fellowship in MFS Orthodontics, Orthodontic World Institute, Barcelona. Currently, she is a professor at the Department of Pediatric and Preventive Dentistry, YMT Dental College and Hospital, Navi Mumbai, Maharashtra. Exclusive pediatric dental practice at Gokul Dham Medical Center, Goregaon, Pedocare Dental Clinic for Kids and Teens, Chembur. She has a total clinical and academic experience of 19 years. She got awards as a distinguished woman periodontist from Indian ISPPD 2025. Welcome, Dr. Subhadra. We will be benefited from your lecture, especially the students. Can you start, Dr. Subhadra?
Dr. Subhadra, you're doing it live, right?
Yes, I'm doing it live.
Okay, fine. Thank you.
Yes, good morning, everyone. So we'll be discussing oral habits. So since the time is limited, I'll be swiftly going through the slides. So I'll be discussing the habits under these.
Madam, your voice is too low.
Is it clear now? Is the audio clear now?
Audio is clear, ma'am.
Yeah, is the slides visible?
Yeah, visible.
Go on a PowerPoint point.
Is this visible?
It's visible, but go on the PowerPoint mode.
It's on the
Wide
slideshow
screen.
mode.
Slide share.
It's visible, Dr. Subhadra.
Okay, so we'll be discussing this topic under these headings, that is definition of the habits and classifications.
If you can put it to slideshow.
Classifier habits. This is on the slideshow. Yes, this is on the slideshow.
While sharing, you can choose the screen to share. Then it will go on full screen slideshow.
Yes, I'm sharing the entire screen. And this is on the slideshow. Is this on the slideshow? My slides are visible?
Not yet.
It's visible now?
It's visible, but it's not in the. It's not covering the entire this thing. You'll have to put it on a slideshow.
It's on the slideshow. Is it visible now? I'm on the slideshow.
No, ma'am, your screen is not visible actually. Otherwise, please share the entire screen, ma'am.
Is the slide visible?
Slides are visible, ma'am, but not in the full screen.
I'm on the slideshow right now.
Or slideshow apply.
Now, is it applicable? It's visible?
Yeah,
it's
ma'am,
sharing the
it's
entire
visible.
visible
Please go
entire
ahead.
screen.
Yeah,
Okay.
you can continue.
Okay, thank you. So we'll be discussing this topic under these headings, that's definition of habits and classification, thumb or digit sucking, pacifier habit, tongue thrusting, mouth breathing, lip habits, bruxism, nail biting, cheek biting, and masochistic habit. As I said earlier, I'll be swiftly going through the slides, and students can feel free to take the screenshots. So these are the definitions. There are multiple definitions of habit. These two are the voucher definition is the most comprehensive one. If you can learn this definition, that's good. Otherwise, the easiest one is given by the Dorland that says that fixed or constant practice established by frequent repetition is what is habit. Then these are the other definitions by Butterworth, Matheson, Tandon, Moyer, and Salter and Hogborn. And these are the classification by various authors, that is by James, Kingsley, Finn, and Klein, where they classify the habits into empty, meaningful, or compulsive, non-compulsive habits. That is, compulsive habits or the meaningful habit means there is an underlying psychological bearing. That is, the child has some psychological association with the habit. Useful habits, that is the sucking habits, or the harmful. All the other habits what we are studying here are deleterious habits. That's why they will be harmful habits. Then there are functional oral habits and muscular habits and combined. Functional is only the functions of the are altered. In the muscular habits, there is muscles are at fault. Further, there's a classification by Morris and Bohanna as non-pressure habits and pressure habits. That is, non-pressure habits are the ones which are the new muscles exerting pressure. But in pressure habits, the muscles are at fault and they're exerting undue forces on the dentro-alveolar and skeletal structures. Sucking habits are further classified into nutritive and non-nutritive habits. That's non-nutritive habits of thumb sucking and pacifier habits. Let's look at thumb sucking. So thumb sucking is seen as early as 29 weeks in utero. This is because of the two reflexes, that is sucking reflex and rooting reflex. Sucking reflex develops early because the child has to get trained in this to fulfill the nutritive needs as soon as the child is born. And this reflex disappears by 3 to 4 years. That's why earlier the thumb sucking was considered normal in children 3 to 4 years. But anyway, that understanding has slowly changed. And the rooting reflex. Rooting reflex is the area around the mouth and the cheek are highly sensitive. They're rich in sensory supply. So any object which touches this area, the child turns the head towards the object and opens his mouth. So these two reflexes are very important to meet the nutritive need of a newborn. So thumb sucking is because the thumb is an object which touches the cheek, and the child turns the head towards thumb and puts the thumb or the digit into the mouth. So it's also an indication that the child has developed a good muscular coordination and he or she is able to reach the face with hand. It's also an indication that the child is trying to explore the environment by putting objects into the mouth. Because at this stage, newborns, infants and toddlers learn to explore the environment with the help of through their oral cavity. These are the definitions of thumb sucking. This is a classification based on the gender, chronological age, and the when the child performs the habit. There are various theories proposed to explain thumb or digit sucking, why it gets retained to a later stage. According to Freud theory, we all know that in newborns or in infants and toddlers, oral cavity is the erotic zone, and by sucking or by suckling, the child derives gratification. So if there is not adequate gratification through suckling, that is on the breastfeeding, the child is going to derive the gratification by sucking on thumb or a digit. So according to this theory, if we forcefully try to intervene with the habit or intercept the habit, it can result in insecurity or anxiety or the psychological issues, and child might substitute with less desirable habits like self-soothing or pulling the hair or other habits. According to Benjamin theory, uh, it's the separation from the mother. It is not really of the oral gratification. It's a separation from the mother, because in an experiment on rhesus monkey babies, where the rhesus monkey babies were placed in a cage with mother-like structures, and some babies were placed in a cage without the mother-like structure, and both were provided nutrition through water. Those which were placed in the cage with mother-like structure did not develop digit or thumb sucking. Those which were placed without the mother-like structure developed thumb or digit sucking. This is to say that the security or the warmth provided by the mother is more important in preventing the thumb or digit sucking. And there are many social and cultural studies also, like Eskimo study, where Eskimos carry their babies on the back or throughout the day. So the incidence of thumb sucking or digit sucking is not seen. Whereas Burlington is an urban society where the most mothers are working. So there is high incidence of thumb and digit sucking. According to learning theory by Davidson, which is proposed in relation to thumb or digit sucking, the thumb sucking or a digit sucking is nothing related to oral gratification or separation from the mother. It's just a learned behavior by observing the other siblings, and there's no emotional or psychological problem, and if we intercept the habit, there will not be substitution with other habits. The counter view is that most children who indulge in thumb or digit sucking exhibit increased anxiety. According to oral drive theory, it is increased duration of nursing actually increases the oral urges, and that again prolonged result in habits, thumb sucking habit. According to Johnson and Lawson, it's the combination of inherent biological drive for sucking, and because there is already a sucking urge which is fulfilled by breast or bottle feeding, but still there is surplus sucking urge which is met with by unrestricted breastfeeding, thumb sucking, or pacifier habit. That brings about the satisfaction. If that is not done, then it will result in frustration or anxiety in the child. So these are the various predisposing factors, that is parents' occupation, the presence of the mother, number of siblings, order of the birth, the social adjustment, that is stress or psychological issues, peer pressure, or the feeding practices, whether it is a prolonged breastfeeding is present or not. When we are evaluating a patient with thumb sucking, so we have to understand what is the emotional status of the child, whether the child associates the habit, is there any underlying psychological association with the habit, whether it's a meaningful habit or an empty habit, whether it is performed at daytime or nighttime, or it's active or passive. That is, active means the child exerts pressure, active muscular pressure, or it's just the child is just placing the hand within the mouth. And also information from the mother regarding feeding practices, parental care, and presence of other habits. So oral manifestations or the clinical features depend on these factors, the intensity, frequency, and duration of the habit. These are called trident of habit. The fourth factor, that is direction in which the child performs, that is whether the child pulls the thumb or just sucks on the thumb. All these are going to determine the clinical features. Extraorally, you will see reddened, clean, chapped, short fingernail. And if the child is performing the habit for a very long time, you can see fibrous, roughened callus also on the superior aspect of the finger. The finger could be deformed. The lips are hypertonic, and lower lips usually exhibit hyperactivity because of the hyperactive mentalis activity. Maxillary protrusion and mandibular retrusion, because the child, if exerting pressure on the prepalate, the maxilla will move ahead. Convex appears, profile is convex, and the mandibular plane is increased. Flayed upper maxillary incisors, open bite, retroclined anteriors if the child is resting thumb on the lower incisors, and crossbite. That is because in this patient the tongue is at a lower position and buccinator is exerting undue pressure on the upper posteriors, that will result in posterior crossbite. Lip incompetency, and because of the increased overjet there will be lip trap, and lower tongue position, because of which there will be increased tongue thrust and mouth breathing also seen with thumb sucking patients. And there could be increased teasing by the peers, which can result in low self-esteem, increased risk of poisoning, speech defects, mid-ear infections, and enlarged tonsils. Before we undertake the interception of thumb or digit sucking, we have to evaluate what is the emotional significance of the habit to the child and the age of the patient and status of the occlusion. Emotional significance is important because the child is highly dependent on the thumb or the digit sucking and is not ready to give up the habit. At that point, the orthodontic appliances may not be effective. Only when the child is motivated and ready to give up, the orthodontic appliances would be beneficial. So there is psychological approach, there's mechanotherapy. In the psychological approach, we should counsel the parents and counsel them from not to scold or frighten the child, and instead they should use a positive reinforcement method or friendly reminders can be used. And Brower suggests that constructive parental education is of paramount importance and avoidance of unnecessary regulation should be stressed upon. Lewis suggests that immediate post-weaning period is the most difficult time to handle, and many children tend to indulge in the thumb sucking or digit sucking habit during this period, and children should be encouraged to chew on hard food and biting. All these activities have to be encouraged to ensure the oral gratification. You're all aware of the beta hypothesis or Dunlap's hypothesis, where the child is made to sit in front of the mirror and perform the habit. So because of the unpleasant experience, the child will abandon the habit. Chemical treatment is the least effective. Child will one or the other way try to overcome this approach. Coming to mechanical or reminder therapy, according to Weiss and Laser, up to 5 years, no intervention with the mechanical therapy should be taken, whereas Graeber suggests that appliance can be placed between the age of 3 to 4 years. These are two different schools of thought. And before we give mechanotherapy, we should understand what is the child's level of understanding, whether the child is ready to give up the habit and motivated to give up the habit. Parents' cooperation, and important to build a friendly rapport with the child, and it should be goal oriented, and maturity of the child has to be understood. There are various extraoral approaches have been suggested in the literature, like to restrain the elbow, like elbow guard, or using a long-sleeved night clothing to cover the hand, or thumb guard, adhesive bandage. All this can be used. Removable and fixed appliances like palatal crib, hair rakes can also be used. What they do is they break the suction and make the habit unpleasant. So, and also they prevent undue pressure on the anterior teeth. And they also work as a reminder. Palatal crib is considered better than the hair rakes. Hair rakes is if the child is not ready to give up the habit, and if we forcefully use these appliances, it can result in symptoms of irritability, night tremor, and bedwetting. Bluegrass also works on the same principle by breaking the suction and making the habit less pleasurable. The modification is that it has a Teflon roller in the anterior region instead of crib. Oral screen and quad helix can also be useful in intercepting the habit. Oral screen is useful in case of children have a nighttime thumb sucking habit and they have a mouth breathing. So it can be utilized to intercept both the habits. Quad helix again breaks the suction and makes the habit less pleasurable, and it can be used to correct the posterior crossbite. So there is, according to this Cochrane review, the palatal crib and palatal rakes both are useful for intercepting the habits, and psychological counseling are also helpful, but the quality of evidence available is low. So they suggest that palatal crib is better than the palatal arch. The pacifier habit. So as we discussed with the thumb sucking habit, there is surplus sucking urge, which is to be met with unrestricted breastfeeding, thumb sucking, or the pacifiers are used. Pacifiers are used to soothe the babies. So, but prolonged usage of the pacifier can result in malocclusion. That is, if it is used beyond 18 months, it can result in anterior open bite, posterior crossbite, class 2 primary canine relationship, and increased overjet. Anterior open bite is the most common malocclusion noticed with non-nutritive sucking habits. Along with that, if the pacifier habit is used beyond 12 months, it can also increase the risk of mid-ear infections. That is because it interferes with the drainage of the eustachian tube because of the elevated level of the soft palate. And the counter view is that it protects against the sudden infant death syndrome because it holds the tongue ahead. Other issues can occur, like it can result in asphyxia, damage to lower lip, gingival damage, botulism, and the chemicals used in the pacifier can also be of concern. And there is latex allergy can also occur. So the AAPD in its policy on pacifier does not advocate to refrain from pacifier usage, but it suggests that the habit should be curtailed before 36 months of age, and when it is used, it should be boiled for 15 minutes, and or chlorhexidine spray can also be used to clean the habit, clean the pacifier. So non-nutritive sucking habits result in malocclusion, and longer the child uses the pacifier, the more the chances of habits, according to this systematic review. So, and breastfeeding is protective because that will result in shorter duration of pacifier habit. tongue thrusting habit. Oh, let's see what's infantile swallow and mature swallow. In the infantile swallow, the anterior tongue tip is thrust between the gum pads and mandibular thrust forward, and it is stabilized by facial muscles, and there is lip constriction. This is helpful in expressing the milk. These are the muscles involved in infantile swallow. During transitional swallow, that is when teeth start erupting, the child transitions from infantile swallow to mature swallow. Here, there is diminishing of buccellator activity, and there is contraction of the mandibular elevator during swallow to stabilize teeth in occlusion. During mature swallow, the tongue tip is placed on the incisive papilla behind the incisors, and the mid portion elevates and contacts the hard palate, and posterior aspect forms 45-degree angulation to the pharyngeal wall, and there is lip seal entirely throughout the swallowing, and there is the masseter flexes and brings the molar in contact. But there is no contraction of the mentalis muscle, orbicularis oris, or any other facial muscles. Whereas in a retained infantile swallow or tongue thrusting, which is an abnormal swallow, the tip is thrust between the incisors, and sometimes it even contacts the lower lip. The mid portion is maintained at a lower level. It does not contact the hard palate, and the posterior aspect is also at a lower level. There is faulty masseter activity, and there is hyperactivity of the orbicularis oris and mentalis muscle. These are the definitions of tongue thrusting. This is the classification based on etiology of the. This is a classification based on the type of the tongue thrust and the clinical outcome. So let's look at the etiology of tongue thrusting. Tongue thrusting most commonly is because of the upper airway obstruction. That is because whenever there is the upper airway obstruction due to enlarged adenoids or tonsils or repeated upper respiratory infections, the tongue is placed ahead to allow the breathing. So that results in tongue thrusting, and neurological disturbances like hyposensitive palate or repeated the brain injuries can also result in anterior positioning of the tongue because of lack of muscular coordination. Even the tongue thrusting could be functional adaptability to achieve anterior seal when there is missing incisors, increased overjet, or open bite. In case of bottle feeding, where the tongue is positioned lower and there is no active contractions of the muscles, it's more of a passive feeding, or the child is on soft diet for a very long period of time, and when there is no where there will not be transition from to the adult swallow pattern because the child is not introduced to hard consistency diet, can also result in tongue thrusting habit. It can be secondary to other habits like digit sucking and pacifier sucking habit because there is anterior open bite as well as lower tongue position. And it can be hereditary because there is hyperactivity of the muscles, anatomical issues like in microglossia, anesthetic throat, or repeated trauma, but these are very rare etiological factors. So it's important to evaluate the history of repeated respiratory infections, sucking habits, other neuromuscular problems, and feeding practices, because they could be contributing to the development of tongue thrusting. Tongue size and shape has to be evaluated, and you have to evaluate whether there is lateral scalloping. That's because of macroglossia, but that's a rare etiology. More common etiology is the lingual frenal attachment or ankylosing. If there is a high lingual frenal attachment, it can restrict the tongue movements and prevent the tongue from reaching the palate. That can result in tongue thrusting. And the functional examination, we have to evaluate the mandibular rest position and various swallows like unconscious swallow, command swallow of saliva, command swallow of water, unconscious swallow during mastication. This has to be observed during clinical examination. Masseter and temporalis muscles have to be palpated when the patient is swallowing and assess their activity. Lip apart swallow, where we pull the lower lip apart and ask the patient to swallow. If the tongue is thrust between upper and lower incisors, or there is activity of the orbicularis muscle or the mentalis muscle, it is an indication that the child has tongue thrusting. Because the tongue exerts about 400 gram pressure, it is going to distort the dentoalveolar structures. It can result in increased overjet if it is an anterior tongue thrust, and there will be generalized spacing in the maxillary anterior teeth, and maxillary constriction and posterior crossbite because the tongue is at a lower position and the effect of the buccinator muscle is not counteracted by the tongue. So that will result in posterior crossbite and anterior or posterior open bite based on whether it is an anterior tongue thrust or a posterior tongue thrust. Treatment involves myofunctional therapy, speech therapy, mechanotherapy, correction of malocclusion, and surgical treatment. Like all the other habits, correction of the etiology or elimination of the etiology is important. So if there are malocclusions like open bite, increased overjet, this has to be corrected. And if there are enlarged adenoids, tonsils, or high frenal, limited frenal attachment or frenal restriction, lingual frenal restriction is there, that has to be surgically corrected. Myofunctional therapies also can be helpful in training the tongue. 2S and 4S exercises can be helpful. This you can read in detail in contemporary orthodontics textbooks by Profit. And other exercises like whistling and recitation from 60 to 90 and yawning, all these can be helpful. Mechanotherapy is required for re-educating the tongue to its actual position and hold the tongue in its confines. Pre-orthodontic trainers which have a tongue tag can help to train the tongue to its normal position, and tongue cribs and double oral screen can also be helpful in tongue thrusting habit. So even this systematic review suggests that all the orofacial myofunctional therapy, crib appliance, habit corrector, and soft tongue retainers all are helpful in tongue thrusting habit. Speech therapy is not indicated before the age of 8 years. If there is a distorted speech, then after 8 years, speech therapy can be advocated. Mouth breathing. These are the definitions of mouth breathing. So mouth breathing is common between the age of 5 to 15 years because the lymphoid tissues are hyperactive at this stage. According to the study, there is 55% prevalence of mouth breathing in 5 to 12-year-old children. 84% of the mouth breathers suffer from some degree of obstruction, upper airway obstruction. This is the classification based on the etiology of mouth breathing: anatomical, obstructive, or habitual. Habitual is after the interception of another habit like digit sucking, the child still continues to mouth breathe. The etiology, there could be developmental and morphological anomalies like asymmetry of the face, abnormal development of the nasal cavity or nasal turbinates, short upper lip, underdeveloped or abnormal facial musculature, partial obstruction due to deviated nasal septum, localized benign tumor, narrow maxilla, or repeated traumatic injuries to nasal cavity, infection and inflammation because of allergic stomatitis, allergic rhinitis, enlarged adenoid tonsils, genetic factors. Typically, mouth breathing patients exhibit adenoid faces, that is long, narrow face and constricted external nares, narrow nose, and passage, flaccid lips, expressionless face, dolichofacial pattern. All these are typical features of adenoid faces or mouth breathing patient. Intraorally, you would see protrusion with spacing of the upper incisors because of the flaccid upper lip, and also these children tend to have a lower tongue position and tongue thrusting. So according to this systematic review, there is the patients with mouth breathing are also at high risk for atypical swallow. So that this is a combined, what you see clinically could be combined effect of tongue thrusting and mouth breathing. Because again, mouth breathing is there and the tongue is also at a lower position, there will be constricted maxillary arch and posterior crossbite. The typical feature of mouth breathing is that anterior maxillary gingiva appears reddish, and because it's inflamed because of the dry air entering the mouth, and there is gingivitis and heavy plaque deposition and discoloration, stain deposits on anterior teeth. The speech could have nasal tone. These children also are at high risk for otitis media, that's middle ear infection, dull sense of smell, and loss of taste. Mouth breathing children are also at high risk for sleep apnea syndrome. So while clinically when we are evaluating, we have to ask the parents about the lip apart posture when the patient is awake or while sleeping, and history of repeated tonsillitis, allergic rhinitis, otitis media. And during clinical examination, observe the breathing, whether they have a lip apart posture, and the nasal orifices. Nasal orifices usually are constricted in mouth breathers. And these tests, mirror test, butterfly test, water holding test, and inductive plethysmography is helpful to determine the airflow through the nose on the mouth. Cephalometric is helpful to evaluate the enlarged adenoids. It's one of very good tool to assess enlarged adenoids and also to evaluate the vertical growth pattern. Mouth breathing patients will have a vertical growth pattern. So first approach is to elimination of the cause. If there are upper airway obstructions, they have to be eliminated first through an ENT evaluation. Exercises, once the upper airway obstructions are ruled out or they are eliminated, then we can start with the exercises, myofunctional exercises like deep inhalation exercises, upper lip extension exercises, upper and lower lip combined exercises, or playing windpipe or disc holding exercises. All these various myofunctional exercises are beneficial. Oral screen and pre-orthodontic trainers are also helpful in intercepting the habits after the elimination of the etiological factors. Class 2 DIV1 correction helps in intercepting the mouth breathing, because most of the class 2 DIV1 patients, especially the patients with mandibular deficiency, tend to have a narrow airway. So correcting the advancement of the mandible increases the upper airway dimension, so that will help with correction, intercepting the mouth breathing. Lip habits could be basic, like wetting of the lips with tongue, or it could be like pulling the lower lip beneath the upper incisors, or everting the lower lip. So it could be because there is increased overjet or the proclined incisor, the lower lip is getting trapped under the upper incisors, as seen with class 2 DIV1 malocclusions or digit sucking patients. Or it could also be because the is performed to relieve underlying psychological stress. Lip appears reddened, irritated, and chapped. vermilion border could be relocated and hypertrophied. So you will, if depending on the intensity of the habit and the duration of the habit, you will see the upper incisors are protruded and lower incisors are retruded because there is tend to be hyperactive mentalis activity also, and they could be open bite. Primary habits or the malocclusion first have to be corrected. Without correcting the malocclusion, if we attempt to intercept the lip habit, it may not be effective because there is an increased overjet, and any attempt to correct lip habit will not be successful. Once these malocclusions are corrected, then appliance like oral sheet and lip bumper could be helpful. Bruxism, these are the definitions. Classification, bruxism associated with stressful event, bruxism not associated with any stressful event. Daytime bruxism, nighttime bruxism. It's common in infants when there are new teeth are erupting, even in the mixed dentition period. Bruxism during night time is common when there is during REM stage, that is transition from deeper stage of sleep to lighter stage. So there are local theories suggested that any interferences or irritation in the oral cavity can result in bruxism because there is disturbed afferent impulses from the periodontal structures. Even the interferences developing from malocclusion or a high point from the restorations or irritation from the dental conditions like pulpitis or periodontitis can also result in bruxism. Cortical lesions, that is CNS lesion, can result in bruxism. Patients with cerebral palsy and intellectual disability also show high incidences of bruxism. This could be because of the lack of muscular coordination also. Other etiological factors which have been attributed to bruxism include GI disturbances, nutritional deficiencies, enzymatic distress, allergies, and endocrine disorders. The underlying psychological factors have been strongly attributed to bruxism, like a feeling of anger, stress, and other inability to express emotions. In this systematic review, they also cite that sleep breathing disorders, that STB, and overuse of screen time, along with other etiological factors like psychological factors, could also be the reason for sleep bruxism in children. Clinically, you see bare facets and repeated fracture of the restorations. Sometimes the involvement, if the severe involvement of the pulp. There is mobility of teeth and morning time headache, muscular tenderness and TMJ disturbances. So there is some evidence to suggest that even in children, bruxism can result in TMJ related disturbances. Parents might report grinding or tapping sounds at night, soft tissue trauma, small ulceration along the occlusal line. Treatment involves removal of any local interferences like high points correction or coronoplasty or malocclusion correction, and the night guard use also has been suggested. And in case of restorative therapy, if there is severe abrasion with pulpal involvement, pulp therapy may be required, and stainless steel crown is the restorative material of choice for children with bruxism because other restorative material will have repeated fractures. And counseling is of importance because most of the children with bruxism will have some psychological issues to be addressed. Relaxation and drugs have also been suggested to treat bruxism. Biofeedback, electrical method, and acupuncture are other alternatives. Cheek biting is holding the cheek or biting the cheek between upper and lower posterior teeth. Clinically, you would see ulcers on the level of occlusal line, open bite, and tooth malposition can also occur because of cheek biting. Oral screen is the appliance of choice for cheek biting. Nail biting has been attributed to stressful or the psychological issues, that is mostly the psychological stress. It's absent, that's because it's absent before the age of 3 years, and there is a sharp rise of nail biting incidence in 4 to 6 years old, and in 7 to 10 years old it's a constant level. That's 4 to 6 years probably because they are starting the schooling, and that could be the reason for sharp rise in the incidence. And again, the adolescent period, there is a sharp rise. Etiological factors, emotional problems, and stressful condition. Inflammation of the nail beds and irregular nail margins are seen clinically. This can result in crowding, rotation, and attrition of incisal edge. Parents have to be counseled, and punitive methods have to be avoided. Mild cases may not require any treatment, and if there are and stress relieving activities have to be encouraged. Light nail polish, light cotton mittens can be used as reminders, and bitter or sour chemicals like pamite or aspatida, these all can be tried, may not be that effective. Self-injurious habits or masochistic habits, where the patient enjoys inflicting damage to himself. They're called masochistic or sadomasochistic habits because the person derives pleasure by inflicting pain on themselves. So this can be classified into organic and functional. Organic is there's some organic lesion in the central nervous system, and they are associated with other conditions like Lesch-Nyhan syndrome, Delange syndrome, or it's even cerebral palsy patients also exhibit high incidence of self-injurious habits. That's because in cerebral palsy patients there is lack of muscular coordination. Functional is further classified as type A, where injuries are superimposed on pre-existing lesion, that is fingernail biting with skin lesion. Type B, secondary to another established habit, that is thumb sucker, puts the thumb in his mouth and rotates the habit to inflict soft tissue injury. Type C is unknown or complex etiology, where there is an underlying psychological component. It could be used as a stress relieving outlet or to draw attention. Here again, the punitive methods have to be avoided. Correct diagnosis is important, whether there are any underlying physiological reason for self-injurious lesions. And referral to pediatrician and psychiatrist is required. And as a dentist, if it is because of the lack of muscular coordination, we can utilize bite blocks or oral screen to prevent self-injurious habits. Even frenum thrusting is considered as one of the self-injurious habit, where the child pulls the frenum between the incisors. This can result in spacing or diastema in the upper incisors, requires psychotherapy, or and can result in ulceration of the frenum. That requires palliative care and habit reminders. Oral shield can be of useful here. So these are some of the textbook references. That is Pediatric Dental Medicine by Forrester, Clinical Pedodontics by Finn, Moyer's textbook of orthodontics, Orthodontic Principles and Practice by Graeber, Contemporary Orthodontics by Profit, and Pediatric Dentistry and Infancy through Adolescence by Pinkham. These are some of the good textbook references for oral habits. So question could be from the oral habits could be like, if it's an essay question, it could be like discuss role of oral habits in malocclusion development in children. In that case, we have to discuss all the habits which can contribute to the development of malocclusion, or it could be like discuss role of oral habits in orofacial development. This should start from all the habits and how the breastfeeding or the thumb sucking pacifier habits, all these are the other habits contribute to the development, abnormal development of the orofacial regions. Long answer questions could be like define and classify oral habits, discuss various theories proposed to explain thumb sucking in child, discuss management of thumb sucking in preschoolers and school-going children, the clinical outcome of prolonged pacifier habit and guidelines on the pacifier usage. So all the what are the pacifier, what are the clinical outcomes, what can happen, and the AAPD guidelines have to be discussed. Discuss in detail etiology, diagnosis, and management of tongue thrusting or mouth breathing or bruxism, or even the other habits like thumb sucking can also be come here. Short answer questions can be like trident of sucking habit, malfunctional exercises for tongue thrusting or to improve the swallow, classification of masochistic habits or self-injurious habits, pacifier use and middle ear infections, how pacifier results in middle ear infections, infantile swallow and mature swallow, Dunlop hypothesis, sucking and rooting reflexes, etiology and clinical features of a specific habit. So that's for any habit when you study, you need to study the definitions, classifications, etiology and predisposing factor, clinical features, how do we diagnose it clinically, and how do we manage. Under these headings, if you divide the habits and study, it will be easy to remember. Thank you and all the best for your exams.
Nice presentation.
Thank you, Dr. Subhadra, for the presentation. There are few questions, there are a lot of questions, but some of the questions, the answers are given in the textbooks itself, so I wouldn't like to ask those questions. Otherwise, certain things that students have asked is myotape in mouth breathing.
Yes, that comes under the myofunctional exercises. So that is one of the approach which can be utilized.
And there's one question asked, why beta hypothesis is called beta and why not alpha or any other thing?
Beta, okay, I'll get back to you on that.
Okay. The difference between tongue crib and ARX.
Tongue crib, it's a crib. I had put the pictures in my presentation, which is it's a crib.
Voice is breaking.
Yeah, tongue crib is, it's like I had put both the pictures. Hair rakes is, it's like a rake, it's pokey thing. Crib is more rounded structure. I had put, if you have taken the screenshot of that slide, there is a, I have labeled it also. What is a hair rake and what is a tongue crib? So you can go back and refer to that slide. I can present if required here also.
And one question regarding occlusal sprints in bruxism. What should be the thickness of the occlusal sprints and whether which one would be preferred, hard or soft sprints?
Soft are preferred. Soft is preferred as a bruxism appliance for children.
Okay. I think the other questions, there are a few other questions, probably if you can take time to answer it in Q&A, it would be better. And some of the references which the students have asked, if you can post it, we'll give it to the ISPPD and they're going to put it on their website.
Sure.
Yeah, thank you, Dr. Subhadra. I would like to request Mr. Dev to please present the certificate of appreciation to Dr. Subhadra. Yeah, thank you. I also request, thank the moderators for this session. I request Mr. Dev to please present the certificate of appreciation to Dr. Divya Sharma and Dr. Srinath SK. Thank you, ma'am.
Thank you so much.
Thank you.
Thank you so much. Thank you, Dr. Subhadra.
Thank you so much, Dr.
Thank you.
Subhadra. Thank you, Dr. Divya. Thank you
Thank
so
you.
much.
Thank you so much,
sir.
Dr.
Thank you, Dr. Srinath. Thank you. Thanks a
Thank you,
lot.
sir. Thank you, Dr. Madhu and team, and as well as ISPPD for the opportunity. It was a nice program. We had a good session. Thank you.
Thank you. Thanks a lot.
Thank you. Thanks a lot. Thanks, everyone.
So the next session will be starting sharp at 1 o'clock, the last session of this PediaRare 6. So kindly join at 12:45.
And we have just very less time now, around 20 minutes. So
Yes.
Dr. Madhu, Dr. Virendra, Dr. Srinivas, all of you, please have your lunch quickly because I
Yes.
don't want you to be hungry.
Of course.
Yeah.
Thank you, sir. We'll
Thank
be back
you.
at 12:45.
Yeah. Thank you. Maybe 12:50 is okay because you
No.
need some time, 25 minutes at least to have your lunch. Yeah. Thank you.
Thank you.
Thank you.